Sciences, GTB Hospital, New Delhi. And the distinction which I feel about her, that she has brought out two great books. First is the stepwise access to hysteroscopy, and second is on intrauterine adhesions, measurements, overview, and hysteroscopy. So I request these two chairpersons to call upon Dr. Jyoti Mishra to deliver a talk on TLH, the stepwise approach.
Thanks, Dr. Nutan Jain, for giving the kind introduction. I feel privileged to be a part of this prestigious webinar. Dr. Jyoti Mishra hardly needs any introduction to this august audience. She is Additional Director in the JP Hospital, Noida. She is Treasurer to UPIAGE. She is Director of Excel Academy of Laparoscopic Training. She is a member of Fogsi Endoscopic Trainer. She is ex-co-convener of Fogsi AUB Committee. She is ex-North Zone Coordinator for Fogsi Endometriosis Committee, and she is ex-chairperson Endoscopy Committee, NOGS. I'll request Dr. Jyoti Mishra to take over the dais and proceed with her talk.
Thank you so much, ma'am. I want to thank all of you for being here. And I think without wasting much time, we'll start this. I'll start with my presentation. I'll just open it. Is my presentation visible?
Yeah.
Right. Would make it full screen.
Yes, ma'am.
Yeah, perfect. Jyoti, go ahead.
Fine. So good evening to all the panelists and the attendees here. Laparoscopic surgery has established its role in the last few decades, and now because of patients' demand, all of us gynecologists, not only the young generation, but the people of my age and seniors also have to learn this technique. There's no other way. So the objectives of my talk today are stepwise approach to TLH, simple cases explained, special emphasis on normal anatomy, use of basic instruments, and how to prevent complications. The success of a surgery starts right from the preoperative workup when the patient sees you for the first time in the OPD. In the history we look at, I'm talking especially with focusing on the beginners and the people who are learning, previous surgeries and diseases. Women with previous cesareans, here we are worried about bladder injury, previous bowel surgery. Is the patient having endometriosis, adnexal masses, PID? These patients are at high risk of bowel and ureteric injuries. BMI of the patient is very important. Very obese will lead to problems of anesthesia, entry complications, need of long instruments, and very thin like this old lady is also a risk because you may hit upon organs and there won't be enough connective tissue to support the organs. Are there any medical comorbidities such as heart disease or lung disease which will prevent a good Trendelenburg position, or is there any knee surgery which would not allow you to give a proper lithotomy position? One second, I'll use an annotation. Yeah. Now, any recent imaging also we have to see. Mostly sometimes we have a patient has been diagnosed with something, and when you do the surgery, something else has also come up, maybe a cyst for which you have not taken a consent. Recent clinical examination, nodularity, which you might have missed or forgotten about, might have developed now, suggesting bowel involvement in a case. All right. 1 second. I need to take this away. Yeah. Consents are very important. Proper consent for laparotomy. In the beginning of your career, do take a consent for laparotomy. We used to take it initially when we had started doing laparoscopy. Ovarian conservation, fallopian tube removal, TLH in full form, total laparoscopic hysterectomy. All these things should be done in the workup of the patient. And counseling about what surgery you're going to do, what complications can arise, what financial burden can come to the patient has to be discussed in the preoperative part. All right. Now, once you go inside the OT before the patient is intubated, you should check your instruments, everything is working. Positioning, low lithotomy has to be given. Ergonomics, people of different heights and stature would be there. So proper long surgery is particularly required. Good focus on ergonomics and your mental drill of what surgical steps you're going to perform with your team. Port placement, this is a standard closed port placement for most of the surgeries, like a 8 to 10 week size uterus. So here position will depend on the uterus size. In previous class, we used to typically say Palmer's point. But for years, we had been going slightly below the Palmer's point because it used to be a little far when we used to come to the wall suturing. Nowadays, Dr. Nutan Jain madam has standardized this. Like she's given specific points. I'm sure she will talk about it. That earlier we would take approximately roughly with some assessment, vague assessment, but now we know exactly where to go for Jain point. Make sure that the bladder is empty. Deep inferior epigastric vessels are also to be avoided when you are putting second ports, and always check the ports after removal. Now, the steps of surgery include, there are 6 steps of TLH. Let us go to each one of them one by one. Step 1, starting with the adnexa. I have some written material here, but I'll be talking to you at the same time. So many times you have these sigmoid adhesions, which are congenital adhesions. You don't have to mark them that a lot of adhesions seen in the pelvis. If they're coming in your way, remove them. In a benign surgery, you may or may not require to remove these. First thing is the adnexa. So pick up the fimbria. Fimbria is the loose end of the tube. So lift it up, stretch it. The vaginal manipulator will take the uterus to one side and then go to all the 3 structures, that is the ovarian ligament, tube, and the round ligament. You should stretch the thing. Don't get too much into the substance of the uterus, nor you should stay away from the ovary. Any backflow should be stopped then and there. Otherwise, this little trickle can lead to a lot of accumulated blood and will unnecessarily keep on soiling your field. Simpson's artery is one artery which comes in the way as you go below the round ligament. So just be sure that you have coagulated that artery. And if you're conserving the ovaries, then stay close to them. And if you're doing IP ligament, just lift them up nicely before you do this. Next step, after doing the anterior and the posterior fold of peritoneum, that is the broad ligament leaves, we reach the bladder. So here it's, one second. Here the bladder has, this is a patient without any previous cesarean. So here you will have a good length of peritoneum, loose fold of peritoneum, which you can lift up. Just like we put in artery in open surgery and lift up the thinned out part, similarly, you can do this with the blades of your instrument. So here, thin this grayish peritoneum, which is the uterus has been pushed up, kyphelate and retroverted, and the cup is pushing it. Even if you don't have a cup, just pulling the uterus will make this prominent. Few fibers which are left. If you lift up the peritoneum, you will find few more fibers of the bladder pillar, which is nothing but the endopelvic fascia, which should be pushed down to get a clean cup over which you are going to do your colpotomy. Previous section, we have a separate talk, although lateral window technique and retrograde bladder filling are useful for that. Always remember, bladder is anterior to the uterine vessels and fat always belongs to the bladder. Step 3 is uterine vessels. So now we do as much as UV fold dissection from the left side as possible. We finish that side and then we come to the right side. So if little stretch of tissue is left, we cut that and push down the remaining fibers. Now these superficial ones, what you are seeing are superficial fibers which can be cut, and then you reach the uterine vessels as we go down. Now I have used different clips I am showing you. Somewhere I'm using harmonic, somewhere NCL, somewhere ligashore, so that you will have an idea with each instrument. If there's one vessel, it's fine. Otherwise, if it's a very broad pedicle, you can divide it into parts and take smaller bites. This is one vessel. So here we mark the lowermost point, and then we'll stay above that. So it's okay if you overcoagulate the upper part, which is the specimen side. But if you go too much down, or if you have a bleeder, then it will be a trouble because ureter would be running close by. Hence, marking the lowermost point is important. There are various ways of taking a stitch, but nowadays with such good energy devices, we hardly need to take a stitch, and this works well. Now, this little bleeding can be immediately coagulated. Whatever you do, keep your traditional bipolar in hand all the time. Step 4 is colpotomy. So now the bladder has gone down, the bowel is down. Your elevator, manipulator can lift up the uterus to keep the bowel down. There's a cup inside. Many people don't use cup. So it is your choice whether you want to use the cup or not, or you have a sponge or holder. And even if you don't use anything, just the texture of vagina, the feel of vagina is different from firm cervix. So here you keep cutting on the cup and going all around. When you reach posteriorly, the uterus should be acutely anteverted, nicely anteverted. Usually bowel doesn't come in the way, and stay above the V of the uterosacrals as you go down. As the pneumo gets leaked, the assistant end sitting there has to cover the vaginal outlet with a wet gauze, with the wet mop. Or nowadays we have a lot of pneumo occluders also, which you can press on the vulva to prevent leak. Here, pull up the uterus, because at all these places, ureter is running very close to the this vaginal angle also. Next step is delivery of the uterus. And during all this, make good use of your 30-degree telescope. So the assistant should know where to turn the cable. The next step is specimen delivery. So any size of uterus, usually the cervix looks the same. Uterus may be very big or small. Now you push this into the vagina, and the assistant can take it. A small uterus can come out easily, especially if the woman is multiparous. Slightly bigger, maybe 8 to 10 weeks, will require few nicks sometimes, depending again on the space in the vagina. So here, we all laparoscopic surgeons also have to be good vaginal surgeons. Protecting the bladder and the rectum is very important because you may do a very good surgery, but a small leak here and there can lead to complications. So we keep on turning the specimen and then take it out. There are various techniques, wedge and all, which I think Dr. Ramesh is going to discuss, so I'll not go to the details. Globular uterus is more tricky, which is like adenomatic uterus, where you have a football, like a globe sitting on a pivot. Step 6 is wall suturing. So suturing can be ipsilateral or contralateral. What material you want to use, it is your choice. We have so many materials nowadays. This is a barbed suture being shown. So usually trainees are very happy that barbed suture, I don't have to tie the knot. Tying a knot is not the only excuse. If you're doing TLH, you should also know how to suture. But the other benefits are also there of barbed suture. It's a constant similar pressure at all the places with same tensile strength, and the tissues doesn't become loose, the sutures don't become loose. But then the polyglactin, which we have been using for long, it is also equally effective. So I don't use barbed routinely, but it is a matter of choice. It doesn't give you much benefit over using polyglactin, unlike in adenomyosis or myomectomy. So take good bites from the posterior anterior tissue. And that is why when you're dissecting the bladder, make sure that you push it really down so that you get good bite of tissue. At the end, this should be the appearance with no bleeding. And I make the assistant pass a finger all around. If there's a small gap somewhere, you can take an extra suture. As well as ureters have to be checked at the end of the surgery. Now coming to post-operative care. So these were the 6 steps of surgery. Now next day when you go for rounds, what do you see? You should see a very nice smiling patient as seen in this picture. We usually start SIPS 6 hours after surgery. And then as she passes flatus and gas movement is there, we start with soft diet. We don't actually rush into giving her food immediately. And the usual antibiotics are these. Catheters removed within 12 to 18 hours, depending on when the surgery was over. And DVD prophylaxis, usually these are women above 40, we given all these women. And patient is discharged most of the time in 48 hours. The take-home message to all my attendees here is learning basic skills of endoscopy has become necessary. So if you don't know the principles, you are going to have complications later on. Know the anatomy. Anatomy is one thing which at every age we have to go and reread. Assist in many simple and complicated cases before you start doing independent surgeries. At the same time, know your limitations, call an expert or refer to a tertiary center. And always, please always keep patient safety first. So one thing is the expert in anything, what you're seeing, all of us were once upon a time beginners. So have 2 qualities. You should not give up. This discussion is going on very frequently. Perseverance is one thing, and patience. These are the 2 things which you need. Keep upgrading yourself with newer techniques and technology. And attend CMEs, conferences. Nowadays, you have so many YouTube videos, unlike us who used to read a book and then go and operate. And never say no to learning. So I was given 12 minutes. I think I have finished. And by the time we have questions, this video will keep on running. Or I'll just go through it quickly. This is a simple, because I showed you in steps. So I thought I'll quickly run a complete video here. We are using an NC. And the adnexa is stretched. So one hand of the assistant is stretching the uterus to the opposite side. And these are the 2 leaves of broad ligament, which you are cutting. By cutting the posterior leaf, you are taking the ureter further lateralized. So that will prevent it from injury. Now, usually there's a white line which you can demarcate in a patient who has not had a surgery earlier, cesarean, but at the utrovesical fold. Now this was a broad pedicle as I was talking to you earlier. Divide it into portions and cut rather than trying to take the whole thing in. Sometimes too much traction on the uterus will not give you a good bite. So ask the vaginal assistant to relax slightly so that your tissue comes into the grip of your instrument. In this case, I wanted to show you a little more coagulation was used. So we expose the ureter, and here you can see the ureter running. So we check the peristalsis of the ureter. In such cases, sometimes you may have collections later on, and even ureter is very fragile organ. It may get entrapped in those adhesions. It may get affected by thermal injury. So one has to be very cautious of ureter at every stage. At the same time, not fear it. Learn how to protect the ureter. This is cautery. We are checking monopolar hook. So just check it in a raw part before you start. Monopolar cannot be checked outside the body. It has to be checked on the patient. So you see your currents are adequate. And then cut it on the cup. It's nice. I feel the device is very good, the cup, but many times it doesn't go. Then on a sponge on holder, we can cut. Or even with the valsalum, you can just lift up the valsalum to show the cervix. Once the initial cut is made, then you see the cervix. So now you can stay very close to the cervix. Sometimes when you reach the sides where the uterines were supposed to be, you will still find vessels in the deeper part. So keep your bipolar ready. You can touch this part with coagulation also. Coagulation foot switch also, you can cut this part. And in the end, suturing, lift up the walled corner, because again, ureter, if you see in this diagram, I have purposely dissected the ureter and showing you this clip. Ureter is very close by, and these ends are not lifted up. You are likely to be including the ureter. So again, at the end, check for hemostasis, and that's the end of the surgery. So with this, I stop my sharing. And Pratibha ma'am, I think I have finished very much in time.
Thank you, Dr. Jyoti. You have really simplified TLH very well in easy steps. And I think it is one surgery which everybody should know. And I just want to ask one thing, like for small uterus, okay, less than 12 weeks, what do you suggest, TLH or NDVH? Because now many people still believe NDVHs are non-invasive and TLHs are minimally invasive. So what do you prefer?
Is it Dr. Richa speaking? We can't see you.
Yes, I'm speaking. Actually, I'm traveling, so the connectivity is not there. So
Right.
yeah.
See, being a lab surgeon, I would always prefer laparoscopy because I feel I can see much more, much wider. I can give a very good support to the through the uterosacrals. But yes, NDVH is something people are doing. But I'm a pro person for TLH.
Maybe if I can just add a point.
Yes, ma'am.
Maybe many people who are doing NDVH, they also feel that if you have any puckering or scarring or pain, tender ovaries, then maybe just put even a scope to do a diagnostic scopy before proceeding for NDVH. So this much we can do in a setup where we have all set up for laparoscopy and still we want to continue with NDVH also.
Yes, sir. Thank you. And thank you, Nutan ma'am and Dr. Neelam Hori and Dr. Jyoti Mishra for organizing wonderful master class. And thank you, UPIAG. Over to you.
Thank you so much. And thank you, Nutan ma'am, for being here. You have to be here with all of us throughout. So now I'll be moving on to the next, I'll invite the next chairpersons. One second. The next chairpersons for the program. I think we have Dr. Pandit. Dr. Pandit, is he here? Dr. Pandit Palaskar is there?
I don't think he has joined.
So, Dr. Pandit, are you there? If you are there, then please, are you in the attendees or somewhere? I'm not sure. If he is not there, then we'll move on to the next talk and come back to him. No, I can't see him.
Dr. Modi is here?
No. Dr. Pandit, are you there? And Dr. Rajesh Modi?
They joined. Maybe you'll have to call up.
Yeah, we do.
Dr. Rajesh Modi is online, but he is not visible.
Okay, Dr. Modi, we can start with your talk also, so we'll invite the chairpersons accordingly. Maybe we can continue with the discussion. In the meantime, I'll just connect it. Yeah, he's here. Dr. Modi, you are there. So should we start with you? You can unmute yourself, Dr. Modi. I think. I spoke very fast. Already I speak fast and I spoke further fast to finish it in time. It's not a small topic. Yeah.
Dr. Modi not picking up.
Maybe you can call Dr. Pandit Palashkar, Dr. Jyoti, if he can.
Dr.
Continue with some discussions by the time they join.
Yeah. So, should I ask questions to you only?
I'll just coordinate. I'm just coordinating.
Yeah,
give your tips.
I was just wondering when I saw Dr. Richa was bringing out the cervix was inside the patient's abdomen. So, to avoid this type of a situation that the cervix which is in the vagina, so it has more anaerobic infection. So we can tie sutures on the cervix, and the vaginal end assistant keeps pulling on the sutures so that the uterus remains taggable. You have a hold on the uterus from outside, and we can morcellate the uterus only to the extent which we need to downsize the uterus and then to bring it out.
Good evening, Dr. Nutan.
Yeah.
Yeah.
Yeah. Hi. Very good evening.
Yeah, it was a very nice and crisp talk by Dr. Jyoti. For the audience interest, I wanted you to share that what are your choice of energy devices which you would like to have in your OT, like a good, I prefer to have a good bipolar and a good, what is your choice and how often do you like to change your devices for a regular TLH?
I know that's a very nice question, and this practically covers everything of TLH. Huh? So Aarti has been very wise in her question. And all of us began with a simple bipolar, Bissinger or a Klippinger bipolar, and then a scissors. But I remember way back in 93, I started using the tripolar forceps. So the tripolar used to be a 10 mm bipolar with a mechanical cutting knife. So the benefit of that used to be that you just hold the pedicle, coagulate, and when you think that the coagulation is complete, then we used to activate the knife. Then over the time came the ultrasonic energy or the harmonic A's. So, we were the key opinion leaders for J&J, and, every city, every part of the country and wherever we were going, we used to showcase tackling the uterine arteries with the harmonic. And the trick, like, many of you, like I do a lot of my uterine artery coagulation with the harmonic A's. So the trick there is that you just keep the jaws open. Don't close the jaws completely and keep activating at one point, then shift a little 1 millimeter, then do the same thing, and then another 1 millimeter. And then as you have coagulated at 3 points, come back to the central point, and then you cut it away. So even harmonic A's can work as a good vessel sealer, which I've been using till now also. And lastly, the vessel sealers like from the Covidian, the Legashow, especially the Maryland tip, which I think Dr. Jyoti was also showing in her videos, and the N-seal, which comes with from J&J. The good point about N-seal and harmonic cases that you have a single generator. So if you have one generator, you can use your harmonic or the vessel sealer. Just you have to change the plug. So I'm very fond of this combination of vessel sealer as well as the harmonic A's. So I think this answers your question, and we keep switching wherever. And then one thing is N-seal, which comes as the articulating. So from if you are standing on the left and doing the uterine artery on the right side, we can articulate, and then it exactly looks like a robotic arm instrument. But I see Dr. Modi here.
Dr. Pandit has also joined in, so I think we'll go in the same sequence.
So we'll go with the same sequence. Okay.
Yeah, so I'll just invite the speaker. Dr. Pandit, are you ready with your this thing?
Yeah, I'm ready.
All right. Okay. Just seeing the program. So
Dr. Pandit, you were not expecting us to be so much in time.
Dr. Malvika, are you there?
Yes, I'm very much.
Yeah,
I'm enjoying all the
conversation.
Yeah.
Please, Dr. Aradhana is also here. Fine. So it's my privilege to invite a NOX president and a very dynamic NOX president, Dr. Aradhana Singh, to chair this session on bladder injuries and prevention of bladder injuries. And she's a senior consultant at Fortis Hospital, Noida. Can I have Dr. Malvika's slide, please? Dr. Malvika Sabharwal is a well-known name in all over North India, and she's a Padma Shri awardee by the President of India, and she's founder chairperson of IG Delhi, and she's done a lot of work in that. So I will invite Dr. Malvika Sabharwal here and Dr. Aradhana for chairing this session. Dr. Aradhana, please introduce the next speaker, Dr. Pandit Palaska.
Yeah, thank you, Dr. Jyoti and Team UPIG for giving me opportunity in this such a prestigious platform to chair the session. And so we have here with us Dr. Pandit Palashkar. He's a gynecologist, endoscopic surgeon, and IVF specialist, director, Endo World Hospital, Aurangabad. And he's General Secretary of IAG. And welcome, Dr. Pandit. He's going to speak on the bladder dissection in previous LSCS.
Wonderful topic. Waiting to hear you, Dr. Palaskar.
Yeah, thank you. Good afternoon, everybody. Thank you so much, Dr. Nutan Jain, Madam, Chairperson of UP Chapter of IIG, Dr. Jyoti Mishra from Noida Hospital, and all the organizers, Chairperson Dr. Malvika Sabarwal, Madam, Dr. Aradhana Singh, for giving me this opportunity to talk on this very common topic of laparoscopic hysterectomy, the bladder dissection in previous cesarean section. I will share the screen. Can you see the screen?
Yes.
Yeah, friends, as the incidence of the cesarean section is going up and up day by day, we are going to have more and more patients with laparoscopic hysterectomy with previous cesarean section. It may be one cesarean section, 2, 3, 4, and we have to be ready with dissection of the bladder in such cases. But I think everybody does these cases commonly. When we are dealing with previous cesarean section, we can have the omental adhesions, intestinal adhesions, bladder adhesions. And to tackle this, Dr. Nutan Jain Madam has designed her Jain point, and we can tackle the omental and intestinal adhesions when we are dealing with the previous cesarean section. But proper counseling of this patient is very important. When we operate such cases, the risk of bladder injury may be 1 to 3% in expert hands. There are risk of intestinal injury, and though it is very rare, in some situations we have to counsel to patient that there may be need to convert the lap hysterectomy maybe to the vaginal dissection or laparotomy. Though nowadays, with a lot of experience, energy sources, and teamwork, this possibility is very rare nowadays. Bladder dissection, everybody knows this lateral endo technique, that is a lateral flap technique. We have to identify the planes properly from the lateral endo and always dissect the bladder just anterior to the uterine vessels on both sides, and you tackle the bladder. Now, I will show you a few videos wherein we can get idea how to operate this technique. This is a patient with previous 2 cesarean section, just bulky uterus. Anteriorly, you can see the bladder is densely adherent to the cervix and the vagina. Here you can see the fold of, this is the adhesion anteriorly. You can see the bladder is adherent to the, at the level of the isthmus, internal os, and you can see the uterine vessels just lateral to the bladder adhesions. So initially you judge how much bladder adhesions are there, and you start the coagulation of the corneal structures. And when you come to the level of the isthmus, the uterine artery, open the bladder like the broad ligament like this, and do the dissection from the lateral side just anterior to the uterine vessels. You can see the uterine artery and vein both are there, and keep doing the dissection from this lateral endo just anterior to the uterine vessels, and keep on dissecting till you reach the level of the cervico-vaginal junction. Then same dissection can be done on the left side. Once you tackle the corneal pedicles, the round ligament and the tubo-ovarian ligament, open the endo like this with one instrument. Just do the parallel dissection to the round ligament. Take the all this yellow fat along with the bladder flap anteriorly, and by traction and counter traction, you enter this beautiful plane. The principle behind this lateral endo technique, because in the during cesarean section we dissect the bladder anteriorly, so in the middle the bladder is more adherent, and laterally where you do less dissection, the bladder is less adherent. That is the simple principle of this lateral endo technique. Once you have done the dissection on the both sides, what remains is the just medial flap of the bladder that you lift with one instrument, and with the energy source you can just chop out that middle structure and the bladder usually goes down completely. So you can see the beautiful planes are there. Usually the bladder is less densely adherent at the lower part than the upper part. Then by traction and counter traction, you keep on dissecting into these holy planes of the dissection, and the bladder has gone completely. This is the last dissection, that is the bladder pillar. Push them laterally and downward, and the dissection is done. Then you tackle the uterine artery, the posterior pedicles, and the dissection is complete. When you do this, dissect the uterine artery, coagulate and cut, you can see the bladder still goes down. In the next video, I'll show you how the bladder can be dissected in 3 steps. The uterine arteries are tackled, colpotomy is done, the salpingectomy, the rest of the part of the hysterectomy is as usual. Give good support to the wall. This is another patient with previous 2 cesarean section. Here you can see there are, even though this is a section with financial incision, the adhesions are still there till the level of the umbilicus. So you have to do the dissection very carefully. There may be the bowel loop lying behind this omental adhesion, so you have to do the dissection in small bits, and you do the complete omental adhesiolysis. Again, this is a patient with previous 2 cesarean section. You can see the same dissection is done, a lateral endo technique. With one instrument, hold the anterior lip of the broad ligament, with the other instrument pull it posteriorly. Do the dissection just anterior to the uterine vessels, and you can see here you can see the bladder is densely adherent at the site of the cesarean scar, and at the lower side it is less adherent. So usually the bladder is more adherent at the upper part, and the lower part is usually virgin plane. You have to just keep on pushing the bladder in the lower direction, and you enter the cervico vaginal junction. So from the right side, we have literally entered to the left side. So only the upper part of the bladder is remaining there. Same dissection is carried on the left side. The left broad ligament is open. Do the dissection below the fat and anterior to the uterine vessels. Here you can see the, even this is a patient with just previous 2. You can see the adhesions are very dense. So it doesn't depend whether it is previous 2, previous 3, or previous 4. It depends on the individual adhesion forming tendency of the patient. You may have dense adhesions with single cesarean section, or you may have no adhesions with previous 2 or 3 cesarean section also. So always keep the fat with the viscera, that is bladder, and keep on doing the dissection, keep on pushing, lift the bladder with one instrument. You identify the bubbles and follow the bubbles, the holy plane of the dissection, and usually you reach the, you do the achieve the complete dissection. Then rest of the procedure as usual. This is in this patient the bladder is more adherent. So I'll show you how the bladder can be dissected at 3 steps. One step is at the broad ligament, second step is at uterine level, and third step when you do the colpotomy. Initially you can see the adhesions of the bladder are very less, but as you go you can see the bladder is more densely adherent. So try to do the dissection by the lateral endo technique. Here we have identified the uterine at the level of its origin, and eventually you can see the course of the ureter just below the uterine vessels. Ureteric dissection is not required always. On the same side, you can see the just pull the broad ligament, and usually the 2 leaves of the broad ligament, they keep on separating. Do the dissection of the bladder, this flap till the lateral pelvic wall, so that you can identify the course of the uterine vessels, and the complete bladder along with the bladder fat lies on the upper flap of the this broad ligament. Here you can see the course of the uterine artery. So you have to hold the complete chunk of this bladder flap. Here you can see we are not able to reach the middle level. So lift the bladder at the center, and with the energy source, cut the bladder flap. this peritoneal flap. You can see the holy plane is there. So always, whenever you are cutting the structure, always lift them, stretch them, and the CO2 usually dissects that plane. You can identify the bubbles, and this is the bladder pillar. Lift the bladder as a whole. Then the CO2 dissects the plane and try to push towards the cervix. At the same time, the vaginal assistant pushes the bladder in the capillary direction. So here the bladder is more adherent at the lower part. So it is not going completely. So what we can do at this level, you can take the uterine arteries. Try to push as much as possible. When it is not going, you can take the uterine arteries. And then once you take the uterine arteries, this becomes like intrafacial hysterectomy, and so that you can push the fascia and the bladder goes down a little more. Similarly, take the other side uterine artery, and see, once the uterine artery is taken, you enter the intrafacial plane of the cervix and try to push this fascia, and along this fascia, the bladder moves further. See, once you tackle the uterine arteries, the bladder, it is easier to push the bladder more further. Same dissection you can do the other side. Now at the third step, even you are not satisfied, the bladder has not gone down enough. You put the vaginal tube or vaginal obturator, and then this vaginal tube acts as a platform to raise the vagina, and on this vaginal tube platform, you can still push the bladder down. So if the bladder is densely adherent, in these 3 steps you can push the bladder. So at each step you keep on pushing the bladder down, and you achieve the desired level. So you can see this tube acts as a platform for the bladder dissection, and on this platform you can easily push the bladder down, and then you do the colpotomy. The tube is placed at the cervicovaginal junction. See, the bladder has gone at least 2 to 3 centimeters away from the cervicovaginal junction, and then the colpotomy is done, and the rest of the hysterectomy is completed. This is another procedure of previous 3 cesarean section. Here the uterus is completely adherent to the anterior abdominal wall along with the omentum, and the uterus is ventrally flexed to the anterior abdominal wall. The cervix was pulled out. So what you have to do, same principle you have to follow. Do the complete omental adhesions and do the dissection from the lateral side at the junction of the anterior abdominal wall and cervix. Here with the one instrument, you have to push the uterus down, and the vaginal assistant also retroverse the uterus and try dissecting small bits, and usually you get the plane. Here you have to be careful the bladder, because the bladder may be pulled till the level of the fundus. So you have to be very careful. With the traction and counter traction, you usually get the plane, identify the bubbles and follow the proper planes. Here you can see the same principle is followed. The bladder is tackled from the lateral technique. Try to keep do the dissection just anterior to the round ligament, and usually the bladder goes down. So the bladder was more adherent at the upper plane, and at the lower plane, the bladder is less adherent. And once the complete dissection is done, rest of the hysterectomy is done in the usual way. These are the various papers which also says that the lateral endo technique can be used for all methods of bladder dissection, whether the patient is having whatever number of the cesarean section. Suppose these are the various methods that are also mentioned in literature. If you are not able to tackle the bladder by the lateral endo technique, you can take the help of these methods. You can do the vaginal dissection of the bladder. You can take anterior colpotomy incision, and vaginally under vision, it may be easier to dissect the bladder, and the upper part of the bladder may be tackled by the laparoscopy. Another method is retrograde bladder dissection. In this method, you do the posterior colpotomy with take the uterine, do the posterior colpotomy with one instrument. You pull the cervix upward, and you can do the retrograde dissection like we do in the vaginal by the vaginal method. Or in very rare cases, you can take the help of supracervical hysterectomy, though with such expertise now available, it is very rarely required. And whatever precautions you can take, you have to be ready to deal with the bladder injury. This is a patient with previous 3 cesarean section. This is a very old video, and I think this was done almost 18 years back. And after that, we never had the bladder injury. So if you want to safeguard the bladder, I think one in your lifetime you have to do the bladder injury, and that is a lifetime lesson. You can see the bladder was entered because we were operating in the wrong place. So what you have to do, identify the extent of the bladder, do the dissection in proper place, mobilize the bladder completely, and then you can do the suturing of the bladder. Bladder suturing usually you can do in a single layer or 2 layer. When you are you can use the suture material, either barb suture, or this was with a 3-0 delayed observable suture material, that is Vicryl. First layer, continuous mucosal layer, you have to that is the continuous layer, to take the mucosal layer. And while taking this suture, one suture has to be at least 1 centimeter away from the opening of the in the bladder, so there is no leakage of the urine in the post-operative period. And second layer is muscularis layer. It is intermittent layer to support the first layer and to bury the first layer. But nowadays there are various studies which also show that single layer closure is also enough, but we prefer to 2-layer closure. Bladder is drained for 14 days, and usually the patient has no problem. So to conclude, when you are dealing with patient with previous cesarean section, we have to do the proper preoperative counseling regarding injuries to the bladder. We need to have the proper knowledge of the pelvic anatomy. Lateral endo technique is the most commonly used technique, though we have to remember the other methods also. And repair of the bladder, if there is injury, it can be done by the gynecologist in the same sitting. Thank you so much again, Nutanjan Madam, Dr. Jyoti Mishra, and the organizers for giving me this opportunity to share our views regarding the bladder dissection. Thank you so much.
Thank you very much, Dr. Pandit. That was excellent.
Thank you.
You showed beautiful surgeries with lateral dissection, lateral window technique of tackling the bladder. So, which is very, very safe. But here I would just add one thing, Pandit, that I do land up using a method in which I go in from the center. Firstly, let me say that in previous cars, I find it more easy to deal with it laparoscopically, and also to continue to operate in a very similar manner as I would do for other surgeries. Start from the center and go to the lateral sides, because using your bowel clamps and lift up the bladder, and using just simple scissors, start from the center. As you give the nick, like you mentioned, the carbon dioxide goes in and forms a, the loose areolar tissue just gives way. So this is something in which a simple bladder is, it's a simple case. But there are cases where the bladder will be totally adherent, in which there are situations when you have to do the retrograde filling and delineating bladder repeatedly, maybe 2 times during the surgery as you proceed. So what you have shown is excellent, with good take-home messages. And I must appreciate the kind of, and especially the ones in which you have shown the editions which are going high up, wherein the fundus is getting involved. Because I remember having initial cases, like you said, 18 years back, even I had a case where you start to do adhesiolysis and a small nick is made, and you know immediately that you've entered a bladder. So no problems. You have to command endosuturing and proceed, like you mentioned beautifully. Thank you so much, Pandit.
Yeah, thank you, madam.
Because I've tried to see the chat box. I don't see any.
I think everybody is mesmerized and so much engrossed in the talks.
Yeah, I was just trying to put in one newer approach. I think if you stay on, Pandit, you will see in few of my videos, I have started the posterior approach.
Yeah.
So I'll be showing in the difficult cases, which I'll be covering now. So rather than the lateral, and now I prefer to call it, and I'm sending it to AG and also for this year. So we call it a uterine artery first. As you
Yeah.
have also considered few times
Yes.
that whenever there is difficulty, do the uterine artery, that opens up the fascia.
Yeah.
So
Yeah,
I'll show you in my videos. So if
Yeah.
you just stay on, you can have a look.
Yeah,
So
madam.
guys,
Yeah.
we look forward to that.
So, madam, we have so many techniques. So, no,
I know.
we can't stuck to only
Yeah.
one technique.
One technique.
All patients they present with different adhesions. So, if one technique doesn't suit, you have to go for this, that. So, we have to be always ready with all difficult situations
Yes.
and
Very nice,
methods to
Dr.
tackle
Pandit.
them.
Yeah.
Thank
Yes,
you.
wonderful.
Thank
Absolutely
you so much,
right.
Dr. Pandit, Dr. Malvika, Dr. Aradhana, for chairing the session. And Dr. Pandit, your talks are very informative. I invite for the next session on ureteric injuries my chairpersons, Dr. Shweta Mathur. She's the current secretary of NOGS, and they're all coming out with very good ideas. So we are having some interesting things happening in NOGS every month. And she's a past treasurer of NOGS and in clinical practice for more than 20 years. Our next chairperson is Dr. Punita Bharadwaj. She's a consultant, senior consultant gynae endoscopy at Gangaram Hospital and very active in academics as well. So we welcome both of you to please chair the session of Dr. Rajesh Modi on ureteric injury.
Thank you, Dr. Jyoti and UPIAG for having me. It's a big privilege to be chairing this session of Dr. Rajesh Modi. And this webinar is a star-studded one, having all the stalwarts in the field. And I would like to welcome Dr. Rajesh Modi. He's a very senior gynecologist and robotic and endoscopic surgeon. And he's also running a training center at, he's director at Akola Endoscopy Center and consultant at Nanavati Hospital, Mumbai. He has been a pioneer in daycare laparoscopic hysterectomy, aqua dissection for bloodless myomectomy, and Dr. Modi's tubal recanalization technique. He has got wonderful videos on the YouTube, and including one of the ureter dissection also. I hope he's showing it today also. And he has been the past vice president on Fogsi 2017. Welcome, Dr. Rajesh.
Thank you very much for the kind invitation and the opportunity. Thank you, Dr. Jyoti, for arranging a webinar after quite some time. And Dr. Nutan also for giving me this opportunity. I won't be having a screen share, so I would request you to double click on my video so it becomes pinned. And then whenever I'm talking, then the video does not disappear, just in case somebody else talks. So I'm supposed to be talking on safeguarding the ureter. Now, for a benign hysterectomy where you are not going to be going into the lateral pelvic wall or doing a lymph node dissection, I personally am of a very firm belief that do not dissect the ureter. As far as a simple hysterectomy is concerned, the ureters tend to stay quite far away, provided you pull the uterus and the structures medially. Traction is the single important factor which helps you to prevent ureteric injury in a hysterectomy. So to highlight this, I am going to be talking about the uterine artery dissection or uterine artery skeletonization. So normally when you are doing a hysterectomy, this is the level of dissection which you are likely to do, that you dissect the uterine by pushing the bladder pillar down anteriorly. Now, I have a habit of going posteriorly also, dissecting the broad ligament up to the level of uterosacral, even detaching the uterosacral. Anteriorly, the bladder is pushed down. So this is standard for every laparoscopic hysterectomy, which most of the people do, that anteriorly the bladder is pushed down, posteriorly the broad ligament is slightly pushed down. And then when you have a segment of the uterine from the place where the UV fold has been cut, which you can see is a knuckle part, the place where the UV fold has been cut, and maybe a 1 or 2 centimeter lower down. So this much segment of the uterine is available to be coagulated and cut off. Now, when you are coagulating and cutting off in this particular area, ureter is far, far away. You really do not have to worry about causing ureteric injury at this particular junction. But what I personally recommend is to go one step down in the dissection. Now what I am dissecting is a little bit more of the bladder pillar area. Gently tease the uterine. When you tease the uterine partially, it cooperates. You can identify the vessels very easily. And here you can see that we are pushing the bladder pillar down. This single step of further pushing the bladder pillar down isolates the uterine very nicely. It is what is called as skeletonization of the uterine. This is the transverse part of the uterine from the lateral pelvic wall up to the isthmus, or the area where the UV fold is. Now, when you have this particular segment seen in front, There is no need to coagulate it. Below this particular segment is a uterine. So this is just to be able to visualize where the uterine is. There is, again, I would like to reiterate, no need to coagulate or cauterize this particular portion. But in case there is any bleeding or oozing which happens from the uterine which you have released, then you have a good segment which can be held, pulled medially, and then cauterized. So this step of skeletonizing the uterine helps you to prevent any ureteric injury in a hysterectomy. So here you can see right from the level of the knuckle, which is at the ascending part, to the transverse part, the entire uterine vessel is skeletonized. You probably need about 20 surgeries or 20 TLH where you have done this dissection with an effort to become comfortable with the whole concept. This subsequent dissection is just for the sake of highlighting that you can go ahead, but this skeletonizing the uterine artery away from the vein is absolutely not required. You should be comfortable enough in your handling of the instrument. This is a simple bipolar and scissor. You should be able to dissect the transverse part of the uterine. The ascending branch, descending branch can be seen separately over here. The idea here is be comfortable with the vessel, be comfortable with the vascular dissection, and you will never, ever have to go close to the ureter in any hysterectomy, whether it is a large fibroid uterus, adenomyotic uterus, or even a cervical fibroid uterus. Traction pulls everything medially, so you're not really worried about whether you are going close to the ureter or not. What we have coagulated is at the level of the UV fold. The lower portion we are not touching, we are not coagulating. Where the UV fold has been cut is the level where the uterine has to be cut off. Once you understand the vessels, once you understand the artery and the vein and the bleeding which comes from those areas, your ability to do a hysterectomy improves significantly. Sorry, just give me a minute. There is an audio in my... Sorry. The same step is now being repeated on the other side for the same surgery. Once you have the dissection done, one step beyond, this is the bladder pillar which we are peeling off. Now on the right hand side, because I am using contralateral part, one instrument comes inside. So I have to alternate with the bipolar and scissor. So I'm more tuned to a little more blunt dissection on the right hand side, but the concept remains the same, that we want to push the yellow part, the fat part of the bladder pillar a little lower down. The moment you have the bladder pillar part going down, the uterine transverse part pops up. It identifies itself completely, and the ureter will always be below and lateral to that point. So as long as you are staying above the transverse part, as long as you're not coagulating on the transverse part, you will never, ever damage the ureter. I really don't believe that there is a necessity or a need to skeletonize or isolate the ureter by dissection. It's not required in benign gynecology. So unless there is a specific need for lateral pelvic wall dissection or lymph node dissection in this particular areas, I really do not like to touch the ureter for dissection purpose. A simple laparoscopic hysterectomy is far away from the ureter. Traction plays a key role in letting the ureter stay on the lateral pelvic wall while the uterine is being lifted medially away from the lateral pelvic wall. So when you coagulate and cut, there is no chance of the heat getting dissipated close enough to the ureter to damage it. Bladder, on the other hand, if the bladder is adherent, definitely there is a higher chance of damaging the bladder with ischemia. But ureter, you really have to make an effort to go lateral, cauterize close to the ureter, and then damage the ureter. So do not worry. Only in case of frozen pelvis, where the puckering of the uterosacral has pulled the ureter closer, I would want to be a little more careful about the ureter. But otherwise, benign gynec surgeries, again, I'm highlighting the same concept in the second video over here. This is with the Thunderbeat. I can very well coagulate and cut off in that area where I'm holding. You can see anteriorly, the bladder has gone down. Posteriorly, the broad ligament has gone down, but the pillar has not yet been dissected. Get into the habit of dissecting the pillar down, pushing the pillar down. The moment you push the pillar down, you will notice that the bladder, the uterine, the transverse part of the uterine starts cooperating with you in every single surgery. Maybe in the initial surgeries, you might have some oozing, bleeding happening when you try to push the pillar down because the pillar is a little bit vascular in some situations, but it is not a hemorrhagic bleed. Let it ooze for 5 ml, 10 ml, it will stop on its own. never ever be worried and do not overcoagulate in the bladder pillar area. So this is, I am still dissecting the bladder pillar down over here. Patient was a previous cesarean. So sometimes there is a little bit extra amount of fibrosis in the pillar area also, but more often than less, the pillar cooperates, goes down, and the transverse part of the uterine responds by identifying itself. Gently tease along the length of the uterine vessel. So parallel to the uterine, I am teasing. And because it is parallel to the uterine, the vein does not get avulsed. The artery will never get avulsed. You can hold the artery, you can lift the artery, you can tug and push the artery. Artery is a strong muscular structure. Never be scared of it. Somebody's microphone is on. I'll have to request the host to get to the muted audio for everybody else, please.
Yes, we'll do that.
So this is the transverse part of the uterine now, which you can see is on the lower side. Small oozing which happens, do not worry about it. And below the transverse part is the ureter. Now, how do you really know this? Do you need to see the peristalsis of the ureter? Not really. Once you understand the pathology, once you understand the physiology, the anatomy, and you know where the ureter is in conjunction with the uterine, you really need to stop looking for the ureter in a hysterectomy. It's more in the mind and the head rather than the actual problem. One more surgery where I'm showing the dissection with a simple bipolar, the same concept. It is enough to have simply pushed the bladder down. It is enough to have simply let the posterior wall of the broad ligament gone down, but go one step ahead. Whether you are using a simple bipolar or you are using a thunderbeat or a harmonic, it really does not make a difference. The outcome of a hysterectomy depends more on your ability to do the surgical dissection in the correct plane. If you are in the correct plane, the chances of having any bleeding or oozing are minimal. You do not really need to dissect the ureter to prevent ureteric injury. You just need to be away from the lateral pelvic wall to prevent ureteric injury. And traction definitely is the key factor. I prefer to use the myoma screw. Some people prefer to use the uterine manipulator. Both the things are equally safe. It depends on you. What are you comfortable with? If you feel that you are happier or comfortable with a uterine manipulator, there is no problem. Use it. I am happy with the myoma screw. I feel because I am able to pull much better. I can control the traction with my own hands. It becomes easier for me. So here you can again see the delicateness of your movement is what you need to develop. Buying a better machine or shifting from a vessel sealer to a harmonic is not going to improve your surgical output. But being able to control your tips of the movements, the instrument, the feel of the tissue which you get from the instrument, that is what is relevant and that is what is important. That is achieved by doing more and more number of surgeries. So as long as you are able to get more number of surgeries, as long as you are able to enhance your surgical skill, you will not have to worry about damaging the ureter. Now, this is one of the latest system where you can see the ureter with a glow catheter. So here you can see the posterior leaf of the broad ligament separated, uterosacral separated. The ureter falls back the moment I have separated the uterosacral. So that 1 or 2 centimeter ureter falling back when I have separated the uterosacral makes a significant difference. The ureter actually goes out from your field of surgery when you are going to coagulate and cut off the uterine. So this is a dissection of the same transverse part of the uterine below the bladder pillar area. For me, this has become a routine to dissect the bladder pillar, identify the transverse part of the uterine, and then go ahead and coagulate at the level of the isthmus. You realize that you are really, really far away from the ureter in any benign gynec hysterectomy. This is, I am holding the uterine. I told you, do not be worried about the uterine. It is a strong, muscular, surgeon-friendly structure. The vein, on the other hand, is engorged. Now, when you let the uterine relax, when you let it go back into the pelvis, you see this is the water under the bridge. Now, when you give traction, the uterine here you will see is going to get lifted up. But whatever the ureter is, the ureter stays on the lateral pelvic wall. See, now you can see ureter stays lateral, the uterine is lifted up. So how do you know that you are not close to the ureter? You do not have to visualize the ureter every time. You do not have to dissect the ureter every time. You do not even have to check for peristalsis unless there are adhesions in that area. So do not worry about the ureter creating a problem when you are doing a simple hysterectomy. There are times when you go close to the ureter. Usually if it is a frozen pelvis, severe endometriosis, previous patient operated for endometriosis, ureter is going to be pulled in. So be careful. Maybe in those cases, this IR stent will be helpful. Maybe in those cases, a pre-operative stenting might make the ureter prominent, or do an IVB to understand the place where the ureter might be. But 99% of the times when you're doing a simple benign gynec hysterectomy for a patient, really do not be worried about the ureter. Thank you all for a patient hearing. If any discussion is to be done, I'm open to that.
Wonderful presentation, sir.
Thank you.
Yeah, it's always always crisp and lucid and hits home straight. Very practical advices. And I think fantastic. The safety tips were very good. I don't see any questions in the chat box. And Dr. Modi, one question that the audience, as an audience, one would like to know, how many times do you need to really stent the ureter?
Only in cases of severe endometriosis, when I know that she has been operated a couple of times for chocolate cyst or bowel or for frozen pelvis adhesive lysis, I would want the stenting to have happened, especially the IR stent, the glow stent. But otherwise, there is no requirement. Once you understand your surgical steps, once you understand that you logically stay away from the ureter, you do not need stenting. It does not help.
And how many times, like you emphasized in your videos, that you don't need to delineate the ureter in every case.
No.
In what cases would you like to dissect the ureter in case you don't want to stent? Because a lot of people don't have stent and they are wary of stenting the ureter. So what tips would you give? And
my
gynecologist?
See, as a gynecologist, you are likely to be doing a benign case. Do not stent the ureter, do not dissect the ureter, leave the ureter alone. Only if you are doing lateral pelvic wall dissection for lymphadenectomy, you need to isolate or skeletonize or identify the ureter. Otherwise, ureter, leave it alone, it will leave you alone.
So in cases of endometriosis, grade 4 endometriosis, where you have TO masses which bring the ureter medially, so to say, as in a lot of adhesive diseases with previous operative surgeries, in those cases also, would you like to leave the ureter alone and just stay close to the TO masses and the uterus, or anything else you'd advise to the audience?
No, preferably I would still recommend that do not dissect the ureter. The moment you lift the uterus away, even if it is a frozen pelvis and I am doing a dissection, the dissection is focused more on the uterus and keeping the bowel safe. Ureter generally does not come into the picture unless I'm lost, that the anatomy is distorted and I'm not sure of where I'm going. In that situation, rather than dissecting, see, in a severe frozen pelvis or an endometriosis patient, dissecting the ureter is even more difficult. Because the sigmoid is sitting on it, it is plastered. The IR glow stent is something which I have, so that is what I prefer.
Right. So you do the stenting on your own, or do you think you should involve the urologist for stenting? I think stenting is a very simple technique. So all gynecologists should learn.
Yes. Every gynecologist who has done hysteroscopic cannulation will find the ureter stenting to be much more simpler.
Right. And a lot of people talk about cystoscopy post-hysterectomy. AAGL had issued a statement to check for the ureteric reflux post-hysterectomy. A lot of people were recommending routine cystoscopies. What would be your take on that?
If you can see the peristalsis from laparoscopic camera, that is as good as seeing the jet coming out from the cystoscopy. I don't do routine cystoscopy for my patients because the laparoscopic visualization of peristalsis is much more easier. It is evident and it can be seen at the pelvic brim without any difficulty.
Right, but they also say that peristalsis is not a harbinger for 100% safety of the ureter. So,
I agree to that one context, that if I feel that I have cauterized a little close to the ureter and I'm not sure of ischemic damage, then simply seeing the jet coming will not be sufficient. I would prefer to put a DJ stent and leave it.
Right.
Very
Dr.
good.
Puneeta, we have these
there's
questions
a
answered. We have to move to the next session. We have a
there's
lot
a
of questions.
question in the
from
chat
audience
box.
as well.
There's a
Chat
question
box.
in the chat box.
Yeah, one question you can take, please. Or I think we
Which
have,
says that if you have a retraction of the uterine and there is a lot of uterine bleeding, how do you check for the safety of the ureter at that time when the uterine has retracted?
The whole lecture was based on that. Prevention is better than cure. Because I dissect the transverse part, I don't have that fear. Even if the uterine bleeds, I have already dissected the transverse part very easily. I can lift up the uterine medially and coagulate. So that is the reason why I have started doing this dissection. That's a single most important point. You have to have a skeletonization of the uterine done to prevent this ureteric injury from happening later.
Right. Excellent, Dr. Modi. Thank you so much.
Thank you so much, Dr. Modi. And we all have a lot of questions in our mind, but I think the time is running short and we'll cover most of them in the panel. Dr. Puneeta and Dr. Shweta, thank you for hosting and for chairing this session.
My
We move on
pleasure.
to the next session. We are going stepwise how we go in hysterectomy TLH actually. So our next is a very interesting session. I invite my chairperson, Dr. Chitra Sethia ma'am, a very senior gynecologist of Noida, and she is a consultant at Apollo Hospital and practicing in Noida since 33 years. I also invite my next chairperson, Dr. Dinesh Kansal, who is a president DGES, and she is currently working as a senior consultant, director and head of at BL Kapoor Hospital, and a robotic surgeon of good repute. Kindly, the stage is over to you for the next session.
Okay. First of all, thank you, Shweta, for getting me, Jyoti for getting me here. And it's my proud privilege to introduce Dr. Nutan Jain, who needs no introduction. I think the whole thing is given and the whole thing has been organized by Dr. Nutan. So we just go on to her talk on tackling adhesions with the bowel during laparoscopy.
Sure. A very good evening to all, and thank you, Dr. Chitra, for all the good times, remembering the good times we've had with you in your Noida Society meetings. And at the outset, till my slides are coming, I would like to congratulate Jyoti for bringing up this nice program and a focused program dealing specific issues in TLX. And I'm sure that this is going to be a lot of beneficial use to not only to the beginners, but also to experts. Even I've been taking down notes. I'll show you my notes. Okay, so I still have a difficult task today for you all. That we have been talking about frozen pelvis and grade 4 endometriosis. So I'll be showing a couple of videos and cases with extensive endometriosis and how to go about them. So we'll be tackling that. So my objectives today is to discuss bowel adhesions and describe the strategies to tackle bowel adhesion. And whenever you see that the bowel and the bladder are totally stuck, the uterus is not seen, and then the issue of ureteric safety comes in. So in TLH, where you have extensive endometriosis, like here you have severe DIE, so we use this ICG, and this is the Striker 1688 camera system, which illuminates the ureters in a distinct green hue. So like this case, it might have not appeared to be a very severe DIE, but here if you see, the ureter is totally all the way surrounded by very extensive and stubborn fibrotic tissue. So here, when you have to literally peel off, the use of ICG is highly beneficial. So once we had dissected the ureters away and all the tissue dissected, we had a nice access to the rectovaginal space, and then after this, the TLH gets easier. So here we see that the ICG also stains the roomy cup green, so making the colpotomy still easier in these situations. And whenever you have extensive adhesions, just be careful about the prevalence of double ureters, because you've had them in 6 to 7 cases, and when you are opening the retroperitoneum, in all the cases, you tend to come across double ureters. So be very careful at what you are cutting and what you are not cutting or coagulating. So now just to go in a stepwise manner, the bowel injuries can happen in an entry by the entry related manner. And I'm quite happy that most of the speakers, they spoke in reference to Gen point to avoid the entry-related complications. During adhesiolysis, as we'll be showing you, more complex situations, complex TLH, and lastly, cautery diaphragm, but this is not the concern today. So these are the cases which we are routinely entering by Gen point because these adhesions are in the center, Gen point being far lateral avoids them. So this is a case which presented to us with extensive bilateral endometriomas, but when we went in to the Gen point, we were lucky. Just see how the bowel was just everywhere on the top and everywhere. And now when we started doing the adhesiolysis, this is the anterior UV fold, and this is here the posterior fold, and these were the TO masses. And once the adhesiolysis began, can you see a rich hall of tubercular pus, cold abscess. So this patient, I remember this is a video from when demonetization was announced. So she was an investment banker, and she said, I got late because of the demonetization and I had to deal with my clients. And she got so late that she was rather not. So this was a diagnostic dilemma rather than endometriomas. She had TO masses, and here the bowel adhesions were taken care, and we proceeded with the TLH. So now I'll just show you the technique which I was talking about. So we are opening up the posterior and the anterior leaf or broad ligament. And this is the uterine artery which has been, and now this is the approach which I was talking about from posterior coming to anterior. The UV fold has been very clearly dissected out. And if you see here on this side, this is the uterine artery very thoroughly skeletonized, and you can see how it was spurting. And here the uterine arteries on the other side. So as Dr. Modi said, that having the uterines totally separated out makes a very good point for avoiding. Just see how the uterine artery is here and it is pulsating. So the skeletonization, even in the face of extensive bowel or bladder adhesions, helps a lot. So this is another case. This patient had previous scopy by me for very severe endometriosis. She conceived, she went back to her city, had a C-section, and she had a severe bladder laceration leading to catheterization for 6 weeks. So we were expecting, but just look over here. This is all the bladder, this is the bowel, and you don't even have a look about where the adnexa is. So I'll just show you the clip over here. So as expected, she had previous 2 endometriosis surgery and 1 cesarean section. So there are a lot of adhesions from the omentum. So we should always do a 360-degree check for omental adhesions to see whether the bowel is involved in them or not. And here in this case, because the bladder was lacerated in the previous C-section, so now if you see the uterus is totally covered by bowel from 3/4 of the sides and from the bladder anteriorly. So we have injected huge amounts of vasopressin, and I'm starting in the same manner, opening up the posterior leaf of broad ligament, trying to find the cotton candy space, the bubbles as few people were referring to. And once we just open up, keep opening the posterior leaf. So somewhere we have to find a plane of cleavage. So here, now we are trying to reach up to the level that I can start working over the fundus. So here, in such cases, it's really important to delineate your ureters. This can be done either by plain dissection or here I'm using the 1588 camera system. This was the ICG. So you see that if you do not have the latest camera system, even this is good enough. You have the near infrared image, and this is the ICG. So if you keep dissecting along with this, and even if the bowel loops come, you are in a clear plane. Now we go over onto the right side. You have to always start for the ureteric dissection at the pelvic brim. So here in this case, at the bottom we got the ureters clear, but here if you see, this is all the bowel and the ovaries adherent over to the bowel. So we took a little bigger size of the tip of the manipulator so that you can have very extensive anteversion. So here you see that the bowel adhesiolysis is being done by sharp scissors, avoiding the harmonic to avoid any thermal damage. So we are taking a little part of the uterine musculature over with the bowel to avoid any bowel injury. So in the pouch of Douglas now, because it was a frozen sac, in the posteriorly also there is no respite. So you see all the nerves have been dissected, both the ureters dissected, and now we are proceeding with the TLH. So here you see this is the dissection in the anterior. First the ovary was dissected away, and now on the right side, the posterior leaf of broad ligament opened up, and this is the very adherent bladder. So if you just see, I'm just opening up the anterior from posteriorly, we are coming up. And if you see, this is the roomy cup. Okay. So the bladder is adherent over here, but we found the correct plane of cleavage and we could easily get into the plane of the bladder dissection. So this is what I was calling that we do the uterine artery first and then try to reach the plane of cleavage. And this makes the bladder dissection a very different approach, and maybe I'll have to struggle for a few years to get it accepted for people to believe that doing the uterine artery first in face of such extensive adhesions does a lot. And this is another mode of the ICG and the camera system, which looks almost like the CT scan. So in this case, the TLH was completed by the colpotomy, and then if you see that the bladder was densely adherent, but by having tackled the uterine arteries first, we are able to reach we tackle the anterior neck and rod ligament along with the uterine artery, and the bladder gets displaced very easily. And this is the last step where the closure has been done. So these type of cases cannot be done without tackling the ureters or first prior dissection. So we call the complex gynae surgeries wherever we have 3 factors at least for a complex TLH. So this case had previous 5 surgeries, 3 LSCAs, by transverse scar, and 2 laparoscopy for severe DIE. And she had a very big cyst on the left side. So making videos of such extensive cases is difficult. So I'll just give you a trick. If you see here, these are the inferior epigastric vessels. So we have to start very high up and very laterally and open up the retroperitoneum all the way very high up, even lateral, much lateral to the psoas muscle, which you see here. And then we can reach the plane of cleavage between from the lateral side, and then we are working on to the, again, to remove the bowel from the cyst. So the bowel has been removed quite a lot. But again, if you see, when we started trying to strip up the cyst, literally I had to strip up between the ureter and the cyst itself. So here tackling the ureters and using the ICG was a big boom. So again, on the right side and then on the left side. So in this case, if you see, the bladder dissection has again been done in the likewise manner. The bladder is totally adherent over here, but we first tackled the uterine artery. And if you see here, the bladder remains adherent, but instantly you reach the UV fold. And here again, you see, now we have reached up to the left side. So the bladder has been so densely, pushed away so far. And this is the posterior colpotomy and closure completed. So this was so now this is another complex TLH. If you see that she had a previous cesarean section and surgery and severe surgeries for endometriosis. And if you see here, this is the bladder, and this is all what we saw. For the next 45 minutes, the bladder, I call it a sangam. The bladder, the rectum, the uterus was totally buried. And I'll just show you the video. So if you see that at least 6-7 loops of bowel were totally adherent. And after almost 45 minutes, I could see this bluish right adnexal. So this was a bluish endometriotic cyst. And I used to tackle one loop of bowel, another used to come. So now we are working from the left side. So there was another endometriotic cyst beneath all these bowel adhesions. So again, always you have to approach on the left side. And just see, the bladder and the rectum are totally adherent to each other. This is a kissing bladder to the rectum. So here we see that on the left, on the right side, I am continuing my adhesiolysis. You see, these are the bowel loops. But now I have become bolder and I continue all my dissection only with the harmonic pace. And We take all precautions to keep away from the bowel. And so it was an open and shut case at some other place. So in this case, because we knew, so we have tried stented the ureters. And if you see, that was a dissection completed in the pouch of Douglas. Now anteriorly we are working, this is the bladder and this is the adnexa. So if you just see, my point over here is to first, now just see how easily the bladder has gone. Just see here. So it is such a nice plane of cleavage that we get. So better, I'm just showing you that in the face of this nightmarish adhesions everywhere, the bladder remains adherent on the top, but we reach a very handy plane of cleavage beneath. So this is a new concept. I'm expecting to face a lot of antagonists. Let's see what the points come up. So, but we have been doing it for the last 5 years, and we find that the plane of cleavage comes in very handy. So you see that though it was a totally hopeless case, but the bladder dissection and all the rest completed. So I think we would just this was this. I think we finished. So tips and tricks for bowel adhesion, that ideally the initial trocar should be placed 5 to 10 centimeters away from the previous surgical scar. So in this point, as they have shown, that the joint point remains about 10 to 13 centimeters from the umbilicus. So most of the scars are midline or paramedial. So it does the job. And adhesion to the abdominal wall should be taken down first, and we should always try to pull them a little and try to create a plane of cleavage between the bowel and the anterior abdominal wall. And for all, I would say that better to use the scissors, but somehow over the time, I have become confident in using harmonic ace. And it's very important to identify the white line that the abdominal wall peritoneum meets the adhesions and facilitate the dissection in a bloodless plane. So blunt and sharp dissection is preferable to the use of electrocautery, and energy devices may be used only if an adequate room exists between the adhesion and the bowel. So a very, very important point is, not the least, that the bowel should be very thoroughly prepared. So just a tip that our cases of this type, we have a prolonged protocol. Patient before admission also is kept on a low residual diet for 2 days. And on admission, a mechanical bowel prep is also given. So the take-home message for such cases is that you plan extensively before the surgery and mobilize and motivate your entire team to help you accomplish this successful outcome and difficult surgery. Use the subtle variations, and everyone is an independent expert. These meetings are just supposed to spark ideas and to learn from each other. Thank you very much. And this is my co-director, Dr. Vandana Jain. She is going to be one of the panelists in the last session of panel on complications. So thank you, Jyoti, once again. A pleasure to be here.
Thanks, Dr. Nutan, for such a wonderful talk on advanced surgeries. It's rare to see such beautiful videos. And I also thank Dr. Nutan and Dr. Jyoti for inviting me today. And because everybody is so mesmerized, there's no question in the chat box. They were just watching you. And I have a question. Sometimes it becomes difficult to differentiate between a large soft ovarian cyst and a hydrosalpinx and the bowel tissue. So any tips on that?
I know. I'll just tell you that a large ovarian cyst and bowel, definitely in the cases like I've shown you, it's always there, but a very good camera system. So I would just like to say that I'm lucky these days that we've got the 1688 plus a 58-inch monitor. So, even a little capillary is shown like a aorta. So, the visualization is the key to it. I think nothing else can help. And what we are doing is that adequate bowel preparation, adequate visualization protocols for the ureter, either stents or ICG, and a good uterine manipulator. And a relentless effort and passion to develop something new, something better, so that the existing problems can be tided over.
We are proud of you, Dr. Nutan. Like not only in North India, it's internationally you're famous for your surgeries. And I know you since 90s, and I've been watching you doing most difficult cases where others would say, like, you know, whether to do laparoscopically or not. And I also think these cases are better than laparoscopically rather than by open surgery.
One question I'd like to ask you, Dr. Nutan, in this current day of medical legal issues, do you have a gastrosurgeon on hand when you have all these very severe bowel adhesions?
Yes, I used to have a bowel surgeon some 8-10 years back when I was going into the rectum and into the pouch of Douglas. And the only thing I used to get that they used to scare me. Don't go there. Now it's rectum. Don't go there.
Very true.
Now, yeah.
But you know, from 8-10 years back to now, the medical legal issues have increased about 10 to 20 to 30 times. So do we have someone on hand that in case we face problems, we should be calling them?
Yes, now we are proud that a young colleague, Dr. Siddharth Gupta, is attached with us. He has a OPD in our hospital every day. So, and he is a good urologist also. So our stenting and everything is also supervised, a little more efficiently done.
Yeah.
So we do have them. We do have them. Medical legally, I would just say that even though you don't ask them to scrub, but for medical legal,
I mean, just be on hand.
Yes.
Yeah. Just be on hand so that we can write in documentation that we have had so and so on hand.
Yeah, and you know, and the type of surgeries in which the gallbladder is done. Just the last week we did a case in which she was an obese lady with previous 3 cesarean sections and a big hernia on the left side and a gallbladder to be done and the mesh hernia repair to be done. And we have done, first we did the TLH, then the gallbladder, and we sutured the defect in the first sitting. And just after 4 days that no drain, something was coming from the drain and everything dry. And then we put the mesh on the 5th postoperative day. So such type of surgeries are on the rise because we have a general surgeon colleague with us.
And Dr. Nutan, tell me about the adhesion barriers. Do you use in such cases if you are doing a conservative surgery? No, in not found out. So that's excellent.
No drain. I'm a no drain and no adhesion barrier person. What I do is I do a hydroflotation. We instill about 2 to 3 liters of Ringer's medication with dexamethasone, hydrocortisone.
And I like your idea of ureter, you know, like you're instilling ICG dye. It keeps the ureter soft instead of, or you keep the catheter in, the ureteric catheter.
The ureteric catheter is in, but we do pull it out a little bit. And
so the upper part remains pliable.
Yeah, I know. This is a very firm feeling amongst urologists and gynecologists that by the installation of the ureteric catheter or the stent, the ureter becomes difficult to manipulate. I don't see any difference at all. Rather, it's easy. Even with your grasper, supposing your camera doesn't work, you can just tug on the ureter and feel the ureteric catheter inside. So in fact, it's a boon that you have a tucking something on the ureter.
Okay. I think that's all from my side. Thank you, Dr. Jyoti, and wonderful.
Thank you, Dr. Dinesh and Dr. Chitra ma'am, for being here. And with your expert comments, the program has become much more interesting.
Thank you, Jyoti.
Even I had a lot of things in my mind to ask, but I think we need to move ahead.
Sure.
Yeah, Professor Nisha Singh was not able to join. She had messaged me. Can we have the CV of Dr. Usha Kumar, please? Dr. Nisha is not able to join for some emergency. So it is my pleasure to invite Dr. Usha M. Kumar, whom I have known for many years. And she is working as a principal gynae endoscopic and robotic surgeon at Max Hospital, Saket, New Delhi, and has organized many academic sessions in the past. I welcome you, Dr. Usha Kumar, to please chair this session of Dr.
Thank you so much, Jyoti.
You can introduce. Actually, Dr. Nisha has not come, so you'll have to introduce. And then
Dr. B. Ramesh, most welcome on you on board. and everybody knows you. Your name doesn't need any introduction. He's a chairman of Endoscopy Committee, Fogsi, and president of Bangalore Gynae Society in 2011 to 2012. And he had published many articles on national and international journals. He's the author of 3 books and contributed many chapters in various textbooks. So Aryabhat Award holder, he received this national award in 2011, and Karnataka Padma Shri Award in 2007, Indira Gandhi Sadbhavna Award in 2003, and the Young Scientist Award from Kerala Gynae Society in 1998. Welcome to you, Dr. Ramesh, and I'm sure with your talk, you will enlighten us the new knowledge how to retrieve the uterus after total laparoscopic hysterectomy, which is the most difficult task sometimes when the uterus is big and you don't want to use morcellator, and sometimes the vaginal opening after doing total laparoscopic hysterectomy is too small. So I'll be happy to have you here for this talk, and I'm sure you'll be having good tips and tricks on the talk.
Thank you, Dr. Usha, for your kind words. And thank you, Dr. Jyoti, for your invitation. And my talk is going to be a little difficult because this is the most difficult part of the surgery. So in fact, whenever you come across the big uterus, the hysterectomy is easier, but the morcellation is difficult. This applies for even fibroid also, and both the uterus for removal. So now I will start my presentation. So go to this. Yeah. So it is mainly video slides. So first I will show you how to morcellate. So this is the vaginal morcellation. So
can
all
you
of
make it
screen
share, slide share on this lowermost? Yeah.
Full screen.
Now it is okay?
No. Yeah, it's okay. You can see.
So now any hysterectomy, at the end of hysterectomy, I think the easiest and the most useful method is vaginal morcellation. So you all know the technique by dissection, trisection, quadrisection, and like peeling of the uterus, and there are so many techniques. So at the end of the day, what is vaginal morcellation is you go on cutting the uterus, so till the entire uterus comes out of the way, or in pieces, so that this is not playing.
No, it is not running.
So you go on cutting the, is it playing? No,
no, sir.
Yeah. So you go on cutting the uterus into pieces. And so my favorite thing is to first transect the cervix. So
Sir, it is not playing. Let us first check this.
Yeah.
It is only a PowerPoint presentation which we see. Is it the same view for everybody? I don't think. Dr. Usha?
Yeah, it's same. Yeah, same. It's not running. I think he has to make it slide share, then only.
I think, yeah. And full screen also, I think.
Yeah, full screen, of course.
Pranay, can you please guide?
Yes, slowly it is playing. So the advantage of
no, it's not playing.
Huh?
For us, it's not playing here.
You can stop share and again first open the PPT and then share with the first slide. You can just stop sharing and then again. Yes, it is screen. And if you can make it screen share, that complete full screen, it will be still better. Otherwise, you can play it in the same mode. It doesn't matter. Just let it play.
Okay, doesn't matter. You move the slide. So the biggest advantage of the vaginal morcellation is it is the natural orifice, and you don't have to make a big incision on the abdomen for the morcellation. And the only primary thing you must know is the uterus, the specimen should cross the pelvic brim and come into the pelvis, then only you can morcellate. If the uterus is not entering into the pelvic brim, so it is better that you do the combined morcellation, that is both laparoscopic morcellation followed by vaginal morcellation is the best method. Otherwise, if the uterus is already in the pelvis and already coming into the below the pelvic brim, I think vaginal morcellation is the best method. So why?
Still it is not playing. We are not seeing the
I will just. Okay. And also the advantage, the biggest advantage of vaginal morcellation when compared to laparoscopic morcellation is that there is no spillage of the contents, number one. So number two is that in case of endometrial atypia and endometrial cancer, that the spillage of endometrial cancer into the peritoneal cavity will not be there. The spillage is on the speculum, and at the end of the surgery, you can give a clean wash vaginally and close the vault. So by this, we can remove even specimen like 1.5 to 2 kgs. So vaginal morcellation is the procedure even at the end of hysterectomy. So normally what we do is we morcellate and remove the uterus specimen and go back to the laparoscopy for vault closure. So don't close the vault from below, because the vault suspension is much superior laparoscopically, because the visibility of the uterosacral ligaments are much better, and vault suspension is under vision, and you can give the final wash and come out of the surgery. So I think vaginal morcellation is best of all the this thing. So I go to the next presentation, next slide. So the next one is laparoscopic morcellation.
So you'll have to stop sharing and then restart, because it's only the one picture we are seeing.
So now the video is playing.
No, sir, not yet.
We can't see.
Yeah. Start
you can
sharing.
Stop share. We first stop sharing and then.
Yeah. So that is over. Yeah. And now can you see the picture?
Yes, sir.
Yes.
Yeah. So laparoscopic morcellation is very good, especially for very big uterus, more than 28 to 30 weeks, and where the uterus is not entering into the pelvic brim. So in these cases, we do combined morcellation. That is, first initially we decompress the uterus, do the laparoscopic morcellation, and rest of the morcellation is done vaginally, where you can remove as much of tissues as possible. Next one. So the next one is in-bag morcellation. So nowadays, I think we know that in abroad and all, they have banned the laparoscopic morcellation when such a situation arises, or suspicious fibroid or suspicious endometrial carcinoma. So we can put the entire uterus into the bag and you can do the endobag morcellation. But endobag morcellation has limitations. That very big uterus, like 30, 32 weeks and all, is little difficult to put into the bag. So maybe up to 24 to 26 weeks you trace comfortably. So you can do within the endobag, so that you keep moving it. So first you put the endobag and you fill the endobag with little bit of water, it expands. And so now you put the uterus into the endobag and you can
excuse me, sir,
morcellate through the
nothing is
endobag.
running. Actually, I mean, we would have loved to watch these videos. We are just seeing one picture of laparoscope inside. What to do?
Video is not seen?
No, sir.
Nothing.
You just stop share and then
Dr. Ramesh, you do not see anything on the screen.
You can also restart your presentation. So it seems like when you start the slideshow, PowerPoint stops responding.
1 second.
So means
Just
you
close and
start
reopen
with
PowerPoint.
Presentation first, and then first you play the video, this video now.
It is just video presentation. There is
Sir,
no.
please put it on.
Start it.
Yeah, now you start.
No, play the video.
So now is the video playing?
No, sir.
Oh, let it be slow.
Because your talk is so interesting,
Huh?
we would love to watch the video simultaneously.
Why don't you make it full screen and then play?
Yeah, make it full screen
Yeah,
and then make
full
the
screen.
slideshow.
It is full screen only.
No, no.
Full screen at the corner near left.
Play mode पे कर दो play.
Full screen only.
Should be on slideshow mode.
Yeah,
Right, slideshow
slideshow.
only, ma'am. It is slideshow only mode.
Just click on slideshow on the top. On the top menu, it says animations in slideshow.
Below the red line, sir.
Right, it is on the slideshow only.
It is on slideshow?
Yeah, it is on the slideshow only.
No, it is.
So,
Or if you have these videos that are elsewhere on your computer, you can play one by one rather than the presentation. If they're on your desktop, you can play them from there and slideshow. And then show us. First, make it full screen. Somebody has given opine that first make it full screen, then the video will also play full screen.
Now this will play.
Yeah, now it is playing.
It's playing. Now it's playing. Yeah.
So yeah.
Now can you see?
Yes, sir. Very nice.
Yes, we can see.
Yeah, yeah. So now this is the example of laparoscopic morcellation, wherein you can take large chunk of tissues. This is called ribbon resection or ribbon morcellation, where you can see the entire fibroid can be done within 1 or 2 strips. So we preferably use for the larger uterus, but our first preference is vaginal morcellation. The second preference is laparoscopic morcellation combined with vaginal morcellation. So initially you in-bag in-bag morcellation is the one which you can go to the next one. This is shown already.
Even audience are asking for the previous one also, vaginal. They want to see the first one also.
The first one. Okay. Play
Yes.
the first one also.
Yes. Yeah, now it is playing.
So now it is playing. You can see. So you go on cutting the uterus and convert the circular uterus into the longitudinal strips, so that you take out that hand, that thing. Yeah.
it's not playing now.
It's a little slow, actually, very slow, but just play it, sir. It's not playing. Yeah, now it is playing. Yeah.
Yeah, it is little bit slow, but it is playing now.
It's okay, sir. Yeah.
And I think you should have a bulldog clamps and valsalum, and tenaculum is a very useful, long tenaculum is a very useful instrument, and you should morcellate in between the 2 speculums so that, like there is no bladder and bowel injury. So you should retract both anteriorly and posteriorly. And so you can see, and you must be aware of the lateral vaginal injuries, where you can, your sharp knife can injure the lateral vaginal wall. So that should be avoided. So make it forward. It takes longer time. Yeah. I think this video is not opening much. Yeah, I think, yeah, next is endobag morcellation. So as I mentioned, we make our own endo bags. So best is to use the Euro bag. So you cut off the top of the Euro bag and put a purse string suture over that, and put the endo bag inside, and put the whole uterus specimen. So when this is effective, especially when you are suspecting sarcomas, or when you are suspecting endometrial cancer, or when you have ATP of the endometrium, ATP of the endometrium in the histopathological examination. So you can forward it. I'm sorry for the inconvenience, because some of the videos are idiot has done the presentation. Yeah. So now I think apart from the in-bag morcellation, you can just play it off. So the next is the mini lap delivery of the uterus. So we put just 3 to 4 centimeter suprapubic incision. So you bring out the uterus, you do the hysterectomy laparoscopically, and so you can do the morcellation through the suprapubic. So the advantage of this is even the large uteruses can be done with, can this go up, all these things? All this play it. So you can see here, you can use the towel clips and myoma screws, etc., to deliver the uterus slowly out of the wound. And once you start morcellate from the suprapubic port, you can cut the uterus into the pieces, and remove the fibroids one by one, and decompress the uterus, and the whole uterus will come out through the mini lap. So rather than struggling through the laparoscopic morcellation and spillage into the peritoneal cavity, so these kind of more suprapubic morcellation or even umbilical morcellations are quite effective in removing the large size of the uteruses. So you can go to the next. So this is the mini lap delivery of the uterus. So you can see here, this was a morcellated tissues which are taken out. This is almost 1.5 to 2 kgs. So many times we are able to morcellate by any of these methods, either vaginal morcellation, combined laparoscopic and vaginal in-bag morcellation, and mini lap morcellation. So these are the 4 to 5 methods of morcellation wherein you will be able to morcellate the tissues and retrieve the uterus. Thank you so much for your patient hearing, and sorry for the inconvenience of the videos. I'm extremely sorry for that.
It's okay, Dr. Ramesh. Thank you so much for the wonderful talk. I just would like to add on few points. Like vaginal morcellation is superb, and there are 2 techniques. You can bisect the uterus, you can do the ribbon technique. Ribbon technique is my personal favorite. You just give the circular incision as you showed in the video, keep rotating the uterus, and any size of the uterus, it comes out very easily. Second thing, sorry?
Yes, exactly.
Yeah.
And try to deliver the uterus and the tissues from posterior pouch rather than anteriorly. Posteriorly there is a lot of space. If you put big speculum, so through the pouch of Douglas, you have a lot of space, and keep pulling. And in cases of intramural fibroids, what will happen is you will core out the myometrium first, and the fibroids will remain inside. So you can core out the entire tissues of the myometrium with cutting, and keep changing your blades, and changing your blades, because the moment the blade touches the speculum, it becomes blunt. So in between you keep, and you should have a longer handle of the blade, and plus the blade, you should have at least 3 to 4 blades ready on the table. You should keep on changing the blade so that the morcellation is sharp and faster.
Yeah. Yeah, that's very, very important. And second thing, I have seen a few people, what they do, they rather than doing vaginal morcellation, they try to bisect the uterus with the monopolar cautery, and they ask assistant to hang it inside the abdominal cavity, and they cut it with the monopolar cautery. I must say this is the most dangerous practice. One should avoid it because monopolar current has to complete the circuit. So if the circuit is not complete, you are hanging the uterus in the air inside
and
the
also they can have vulval burns, especially if you use monopolar current for morcellation. And I will tell you, bisection is not a very big help for morcellation. It may bice, you can retrieve the tissues only up to 14 to 16 weeks, beyond which the bisection is not useful. The best morcellation is ada theda morcellation. That is, you cut off the cervix first and catch hold of all the tissue, whatever comes on the way, and you go on removing. So then at the end, the whole uterus will just pops out like outside.
Yeah. And third thing, what I have seen, in very big uterus, we start doing ribbon technique or bisection technique, and we keep pulling the thing. If it is a very big uterus, we get exhausted. And then we try to, out of excitement, we try to pull out the uterus through vagina. So if you do that, then please always check for the vaginal vault tear. Because you take out the uterus, you feel very happy, you close the vault laparoscopically, you leave the patient like this, patient is out of anesthesia, and there is all of a sudden the blood start pouring vaginally. So please, it's very, very important to check the vault tear when you complete your morcellation vaginally.
Not only the vault, the lateral vaginal walls, because you are cutting like this laterally, there could be potentially lateral vaginal wall cuts, which may cause post-operative bleeding. Immediately, there may not be bleeding. So they usually come on, say, within the first week, 5th day, 6th day, etc. And, like there may not be bleeding from the vault. They will be bleeding from these vaginal lacerations. So one has to be, better to suture these lacerations with 20-vicryl so that the lacerations will not become this thing. And another method is fundal pressure. If the uterus is very big and refusing to enter into the brim of the pelvis, like just delivery of the baby, one can give the push from above on the uterus and the surgeon go on morcellating from below. So this bimanual from both the sides will help to push the uterus into the pelvis. The moment the tissues are reduced, so with a strong force, you can push the uterus into the pelvis, just like in cases of the normal deliveries.
The one comment I would like to make here, when you see these lateral cuts in the fornices, mostly when we see it vaginally, then we go to the laparoscopy end. I would suggest if you are seeing a cut high up, stitch it first before doing the vault closure. Otherwise, it will be so much indrawn, you won't be able to reach there. If there's a bleeding small laceration.
If they are very close to the vault, you can include the vault along with the vault lacerations. But if they are mid-vaginal and lower down, it is better to close it from below. And earlier, I was wondering, many patients post-operatively with difficult morcellation, they used to come with bleeding, say on 5th or 6th day or within first week of the uterus, and they used to get annoyed whether the uterus is removed or not. And later on, we realized that these are the ones which were causing the bleeding, not from the vault. It was mistaken for vault bleeding or vault dehiscence. It is not the vault dehiscence which was causing all this bleeding. It was the vaginal lacerations and the vault lacerations which were not addressed at the time of the surgery, which may get infected within few days, especially after the vaginal morcellation, and they may come with post-operative bleeding. So that could be one of the cause. So one has to inspect the vagina both put both the speculums anteriorly and posteriorly. Putting one speculum is not sufficient. Put both the speculum, one anteriorly and one posteriorly, and see deep up to the vaginal vault, and correct if there are laceration, and potentially it is a dangerous on the rectum and the bladder. So you must, when you go back to the laparoscopy, you must always check if there is any bleeding from the rectal area or the bladder area, so that by chance if you have cut the bladder or the rectum, most often it is superficial serosal, so you can just take few sutures on the rectum and the bladder and come out after closing the vault.
Thank you so much, Ramesh sir, and Dr. Usha for chairing this session. And we have stepwise, and as we promised, we have gone in a stepwise manner from the beginning till the end. So now we start with the panel. Dr. Nutan, over to you.
Yeah. So excellent show till now, and the most awaited program on the challenges and complications and the management. And to head them, we have Dr. Subhash Malya, a very young endoscopist from Calicut, and he is also the chairperson-elect of the Fogsi Endoscopy Committee 21-23. And I've known Subhash Malya when he used to be a fellow with Dr. Shailesh Puntambekar, and also had the pleasure of having him at our place. Her co-host is Dr. Jyoti Mishra, who has been a brainchild behind this entire program, and an excellent evening. And over to you, Subhash and Jyoti, to introduce your panelists. And just a word, I would like to welcome Dr. Sudha Tandon, our new treasurer for the IAGE. Welcome, Dr. Sudha, and all the other panelists. Their short CVs will follow. Thank you.
Thank you, Nutan. Yeah.
On behalf of Dr. Malya and myself, we are welcoming our panelists. Our very first panelist is Dr. Sudha Tandon. We know each other for long, and she is a practicing gynecologist and an endoscopy specialist and IVF specialist at Chembur, Navi Mumbai. And she is MOG's IAG Endo Art Conference. So these are contributions. And currently, you are Fogsi chairperson, sexual medicine. There's a long list.
You can go ahead, Jyoti.
Yeah, I think we'll go ahead.
Please go ahead. Yeah, I can skip this.
Yeah, next person, please. The other panelist, second panelist is Dr. Aarti Luthra from Dehradun, Uttaranchal, and she's the president of Dehradun Obs Gynae Society, joint secretary UP IAG, and very actively coordinating activities along with Nutan ma'am. And we have done a lot of work along with her. Next person, please. Dr. Amit Tandon, a well-known face in Agra and whole of North India. And he has been operating very frequently in so many conferences and at Kamlesh Tandon Hospital, Agra. I welcome you to this panel. Dr. Sushila Seni, I didn't see you here. I hope you are there. So we welcome you from your Durbin Hospital, which is a very interesting name. And she's also a brainchild behind so many Facebook Lives and surgeries and panel discussions, which she keeps on organizing. Welcome to this panel. Dr. Vandana Jain, the young, beautiful lady. She is the director of Vardhaman Infertility and Endoscopy Center, Muzaffarnagar. We welcome you to this panel. And Dr. Damodar Rao, yeah. Dr. Damodar Rao, he is a consultant in Obs Gynae Infertility and Laparoscopy at Rao Hospital. Currently, he has contributed to a lot of books, and I see a lot of qualifications, awards. A Fogsi Future Award, Yuva Fogsi Award, so many of them. So we welcome you, Dr. For this panel. Please. Dr. Subhash, I think you can start with your slide share, and then we'll move on to further with the questions. Dr.
Thank you very much. Thank you very much, ma'am. At the outset, I would like to thank Jyoti ma'am and the whole team of UPIAG for this wonderful opportunity. Thank you very much, ma'am. So I think before we go ahead, right. Damodar, are my slides visible, Damodar?
Yeah, make your slide share complete.
Yes, ma'am. Yes, ma'am.
Yeah, it's visible.
Yeah. Thank you very much. I think let's start with this. That ships are in harbor are always safe, but that's not what ships are built for. The job did say that. So basically, what are we doing? We are going to have a complications in laparoscopic surgery. I would like to simplify it towards the nearest motion and the. I think the illustrious speakers prior to us have shown us all about the surgery, how they do it, and how exactly we may go wrong also. Right now, what remains untold is most important. So what you see is this is my dream car and my dream road. Now this is not good enough, in spite of having the best of equipment, instead of having the best of surgeons, sometimes, accidents can happen to the best. They can pull down your confidence, but of course they give you a chance to improve. So in spite of having the best car, sometimes, these things do happen, can't help it, right? So let's understand that all these things that you see on this particular slide, they all go together, they all form together, they have to be in the right alignment, and then this particular thing comes out, right? A very small and a simple car. The same way, when you do a surgery, I think lots of things do go behind it, starting from the beginning till the end, not just the surgical part. So all these things actually should combine themselves pretty well to have a good surgical outcome. And good surgical decisions comes with experience. I think we have a lot of learned and experienced panels. Of course, experience does come with complications, right? So experience is nothing but a complication of somebody else. The lessons that we have learned from surgical mistakes, the banana skins helping. Right. So let me just ask Jyoti ma'am to start with her first slide, ma'am.
All right, so I'll start my screen share. It's seen, it's visible?
Yes, ma'am.
Okay, so I'll go to full screen. So we all like to show on the YouTube channels everywhere we put the best of our surgeries. We edit the parts where we have struggled. So challenges, complications, the panelists, you've already been introduced. I hope I'm visible.
Yes, ma'am.
Okay. So challenges and complications, we are generally going to cover all these things which we actually see in our OTs. The challenges are in the form of previous surgeries, endometriosis, PID, the list is long, and these are the complications which we may have, a long list of complications. So my first question is to Dr. Sudha Tandon, the senior most person here. These are three kinds of patients. This patient had previous 3 cesareans. The second, I have numbered them 1, 2, 3. Laparotomy for bowel obstruction, and third number is operated for frozen pelvis, and she was closed. So what would be, let's stick to case number 1 with Dr. Sudha. What would be your preparation and counseling for this patient with previous 3 cesareans?
Yeah, I think if she's for hysterectomy, right? Because this
we have set all our complications to hysterectomy, ma'am, so that we just
most important is that the complication which is entry related, and 50% of the complications of laparoscopy are entry related. So I think it's important that each laparoscopic surgeon is familiar with at least 2 to 3 ways of entering into the peritoneum. So of course we have to use what is a safe method in this patient, and what I am familiar is using the alternative method, putting the Verey's needle in the Palmer's point or a modified Palmer's point, creating pneumo, and then putting a 5 mm, either a mini laparoscope you can put, or I use a hysteroscope which is 4 mm, because this is what I have, and at the modified Palmer's point, or you could even use a Gynae point, which is an alternate point, and then put the 10 mm trocar cannula under vision. So you could raise the pressure, intra-abdominal pressure, while putting your 5 mm trocar.
How much would you like to increase?
In India, you can go up to 20, though Harry Risha has told you you can go up to 25. But I think in Indian women, I just go up to 20. So that increases the CO2 bubble that is there, so that you'll have more area to put in your trocar cannula. So I think, and you just raise it for about 2 to 3 minutes. And once you have raised, it's not the volume of the CO2, but it's the pressure. So this, and then you put your 10 mm trocar cannula. So when you have a good pressure, it is very tense. So the damage is really less. So this is one way. You can also use an open laparoscopy method, but open laparoscopy method in an obese patients becomes a little difficult.
Yes, ma'am.
And in thin patients, it is safer to do an open laparoscopy.
May I just, with permission of Jyoti ma'am, may I just ask this question to Dr. Vandana Jain also? Like, let's hear from a different perspective. Vandana Jain. Yes.
So at our center, we are usually using Gynae point.
So that is the reason why I put the bait for you, right?
So basically, in previous 3 LSCs, what we usually find is most commonly upper abdomen, we do not find a lot of adhesions. Okay, is my voice echoing?
Yes, yes. Little
Right.
echo, but
Can
it's
you just
okay.
decrease a bit? Yes.
Yeah, it's little echo.
Now is it fine?
Yeah,
So we do not find upper abdominal adhesions a lot of times. Maximum is a 1 or 2 band of momentum. What we find after, we usually enter through Jane's point. We put a very through the Jane's point. And then the first port also we enter through the Jane's point. As we've already mentioned, what is a Jane point?
Yes.
We do not find a lot of adhesions. What we usually find is a stuck up bladder, or sometimes we do find a uterus completely stuck up to the abdominal.
So let's stick to the entry only.
Share your video, ma'am. Jyoti ma'am.
No, we are still on this. And
Your video,
can
your
you see
video,
my,
ma'am. Jyoti ma'am, your video. We can't see your video.
I am visible in my face. I am quite visible. I think I can see mine.
No, ma'am. I think all of us can, right?
The screen.
Since the screen share is on, you may not be able to see me. I don't know. The
No,
screen
your
is
presentation,
visible.
presentation, ma'am.
Dr. Jyoti.
Your presentation, ma'am.
It is not visible. Okay.
No, ma'am.
All right. I'll just go back.
Initially, I got a bit tense whether I'm the only person who missed it. No.
No, I'll just go back to that. Is it visible now?
It's loading.
Yes, ma'am.
Yeah. Dr. Amit Tandon, to you now. Second case, laparotomy for bowel
Can we
obstruction.
have a full screen, ma'am? Jyoti ma'am, can we have full screen, ma'am?
Yes. Dr. Amit Tandon, this is for you.
Yes. So before I go to start this case, of course, going into the history, the cause of the bowel obstruction, if it is mostly, I think they are because of tuberculosis in North India. So I would like to go either through the Palmer's point or through the Jane point, but I would like to use the Hassan's technique for entry.
Any particular reason, sir, for this?
Because sometimes you are lucky that you can enter very well with the 5 mm telescope, but sometimes the abdomen is totally plastered and there is difficulty in the bowel is adherent all throughout the abdomen. So of course, before starting the surgery, the essential protocol of emptying the stomach, sucking out all the gas from the stomach, and a good bowel preparation is mandatory. But my preference would be through the Palmer's point or the Jane point. And the second thing is, either if the abdomen is soft, I can elevate the abdomen very well. It seems that the adhesions are not, plastering the abdomen to itself. I can still go for a direct 5 mm trocar 5 mm entry with the telescope after doing insufflation. And otherwise, I would like to use the Hassan's technique.
So let us play this video. Can you see my video playing? So this is the scar. And here. So coming to Dr. Damodar Rao. Dr. Damodar Rao.
Yes,
yeah. So anything different from what other previous speakers have said? We all have to contribute. Like anything else?
I typically use the Palmer's point, but I just go as close as possible to the rib, like at the subcostal margin itself. And then instead of a 5 mm, I put in the varies, and after insufflation, I put in a 2.9. There is a 3 mm trocar available. So I use the hysteroscope, which probably if you're going to cause damage, it may be less.
Damodar, may I just inquire, like sometimes if the patient is really obese, would a 3 mm scope will you find it easier to use, or are you comfortable using that? Just for the sake of,
if you have good distension, you get long 3 mm scopes, trocars. So it is easy. There's no problem.
Not the microsurgery instruments. Okay.
Not the microsurgery instruments.
Yeah. So let's play this video. So we have gone through the Palmer's point here. The
Damodar,
modified
can we have
Palmer's.
your camera on the transverse mode, please?
I'm on an eye.
No,
yes, that's better. That's better. Yeah.
So Vashimardan is like, so we have put the gas in, and as we enter, let's see what comes inside. Usually we keep the pressure high. So this is what we see inside as we go in. We don't see the uterus at all, and it's all bowel and omental adhesions everywhere. So coming to Dr. Sushila, are you there, Dr. Sushila? I haven't seen you.
No, I did call a couple of times, but then she didn't pick my call.
She could be busy. Dr. Aarti, yeah, you have been quiet till now. So in such an abdomen, now what next? Where will you start from? You don't see the uterus, you see bowel and omentum all over. Dr. Aarti Luthra, I saw you there.
Yeah. So, once we have gone inside, and we have to find a place for putting in a hand instrument. Okay. And a lot of times, if the omentum is stuck, I have a feeling that, our scope has gone through the omentum, and partly if we try to withdraw the sleeve and then put it again like what you have done, and the stuck omentum has gone a little down, and then we can find space to put in another 5 mm trocar for hand instrument, because most of the times on the sides you get some space laterally, and once you put a hand instrument, then you can gradually start doing adhesiolysis and make some space.
If I may add, ma'am, if I may add.
Dr. Jyoti, I just point out, like, ma'am, what ma'am is trying to say, and what I also practice most of the time, you put a blunt 5 mm trocar. If the omentum is adherent to the surface of the abdomen, so because of the pressure of CO2, the planes, the cotton candy plane, it starts forming, and you can bluntly dissect those planes, and then you get a place to put your secondary trocar, and then you can create planes, because most of the time these adhesions are not that dense. They are soft, and once the CO2 starts pushing in, it keeps on giving you a path to separate this plane.
Subhasha, you in the meantime prepare your slides, because now we are starting.
Just summing up one more point to this is, I would always say, the moment we put up any port into this, any scope, always do the alpha maneuver when you see 360 degrees. Sometimes what happens, we would have gone through and through to the bubble. Of course, it's very rare, but then make sure you have seen the whole loop, and then you come out always. And that's something which I've learned from my mistake.
Just elaborate this once again for the audience, because there are a lot of beginners.
It's called the normal one. Whenever we are taught in laparoscopy, we say, but the moment you put your scope, always go 360 degrees.
360 degree, yeah.
That's the alpha maneuver. But of course, when in cases like this, when you do an alpha maneuver or the 360 degree view, you would make sure that everything all around is in. So sometimes what happens is, if there is a small bubble or a bubble, you go through and through this, and you would not even make a mistake of of diagnosing an inadvertent injury. So that's something which I had my own case, so that's why I've been very, very categorical in saying that. Now that we have had a troubled abdomen, we've entered into the abdomen. Now let's see for the sake of discussion, what you've done is we've gone into the 3 clamps, slowly. You've gone into the abdomen, then now go to the first clamp. So what are the mistakes that we have? And the second part is, the moment I have entered here, you can see here. Now, Damodar, can you please guide me through this? How to go about here?
Yeah. Is it a picture or is it?
And as I would always say, you have a problem like, this is not a complication per se. How do you avoid the mistake that I've done here?
Yeah, basically you have to try and not, cut on the uterus as such. Stay away from the uterus. Like in your open surgery, like you told not to go too much on the uterus, and then you stay away, and then you can avoid this, backflow. It's not something that is going to.
No, it is not a complication.
It's not a complication as such, but it's going to be troublesome for you to operate. So it's always good to stay a little away from the uterus and place your instrument, your energy source.
I always say, staying true. I always follow Dr. Modi what he says. That you have followed the 3 clamp method, where you coagulate the middle end, the medial, the middle, and the lateral end, cut in the middle. If you're too close to the uterus, now this is an easy case. Now this is a comparatively easy case to happen. And still, I have goofed up. So this is something which we can avoid now before we go to complication per se. So I thought, let me just play this. Right. Next,
also, can I just add that?
Yes, ma'am.
The cutting should be lesser than how much you have desiccated with the bipolar.
Absolutely, ma'am. I think that's a very, very.
You tend to, you want to finish the procedure fast. So you tend, let me cut little more. But you must cut little lesser than what, go slow. Then that way you can do a very clean surgery. So actually being slow is fast.
I cannot emphasize more what you have said. It's absolutely one of the cardinal rules that we are taught, in laparoscopy. Yeah. Cut less than what is required. I think Dr. Puntamikar always said this all my life. That cut less, because the coagulation doesn't go till in what we see. It seems that as if everything has been coagulated, but it's only the superficial layer that will be corrected and not the inner part. And this is a very important aspect in your vessels. You have to use this principle in your vessels per se. Now, ma'am, Sudha ma'am, next over to you, ma'am. Yeah. This is I have gone after the first clamp, ma'am. I've reached the uterines now, and can you please guide through as to what am I doing or what wrong have I done, ma'am?
Yeah, you probably You've not dissected the bladder peritoneum.
Absolutely, ma'am. I think more than the complication per se, ma'am. Yes, ma'am. Please guide me where I've gone wrong, ma'am.
Yeah, so I think you have cut more than what you have desiccated. Probably you must reflect the bladder peritoneum, dissect the bladder down, and then take the uterines. So that is very important.
Am I
And
doing the right
sometimes
way
there
now?
could be also an ascending cervical branch, and then it may be because of previous cesarean, it may be a little above. So, you could, even while you're doing your cornwall, it could come. So I think it's important that, and also you must retract your, the person who's lifting the uterus, your retraction, either vaginal or with your myoma spiral.
So I think critical analysis of what Sudha madam has done is perfect. And I have gone wrong in 3 or 4 places in this particular places. Again, the first information. Now, Damodar, can you just once again let me know if you can find few more faults with me?
Sorry?
Yeah, can you find a few more faults than what madam has said?
Yeah, you also probably, like ma'am said, there's not been enough coagulation.
I have not pushed the bladder enough. I think
not
that's a
pushed
big
the bladder
mistake.
down enough.
I have not pushed the bladder enough. Secondly, I've
And
ever seen
that is probably the bladder pillar area, maybe.
Yes. And now I've taken a stitch here because I thought it is not stopping with my and still you see sometimes you don't learn from your mistakes and it's very wrong. Again, you see, I'm actually proceeding ahead without even pushing my bladder pillar again. I think you refuse to learn from your mistakes. You refuse to get up from your mistakes, and that is where I may again done it. Now the importance of this particular point again would be that if I go on this side, now you can see if there is a bleeder on this end over here. Now, my next tendency is to go on to the lateral area, and that is when my thermal damage to the ureter can occur. Now, this is an easier case, and still, I have a lot of problems. Imagine if it's a slightly difficult case, it's going to be even more difficult. And in cases like this, I've put a suture here. Can Aarti madam or anybody tell me what I've done is right or wrong, or should I have still gone ahead and done with the bipolar coagulation?
I would have preferred to put a suture little higher because this is too low. So it's better to do it at the level of internal loss, and I'm not too happy with the bladder being pushed down nicely.
Absolutely, ma'am. Absolutely.
I have asked my assistant if they have put a manipulator to push the uterus up so that the bladder goes down. And after doing a good dissection, I'll be happy putting a suture or doing bipolar coag nicely, but slightly higher. You have gone too low near the bladder pillar.
Can I just also add one more thing?
Yes, ma'am.
Yeah, one more point. What happens is with so much of bipolar that you do, the tip of the bipolar, there's a lot of those black
crust, which
will form, and you have not cleaned. If you keep on using the same and unclean bipolar, it is not going to work. All your bipolar machines are very smart, so no energy will be passed. You will be thinking that probably you're passing bipolar current, but just clean your instrument, take it out, you hold with a grasper so there's no bleeding, do a good suction and visualize it properly and clean your bipolar, or best would be to keep 2 bipolars on your trolley.
So to sum up all that I've done, there is all that can go wrong, all the mistakes that I've done, I think this is what I've learned. So I put this video that all the mistakes can be made out, instead of showing a complication per se, right?
Actually, most of the ureteric injuries or whatever happens in simple cases. In large uteri, the vessel is nicely seen actually, and you kind of tend to stay away from the ureter.
Two more things I would say, Dr. Aarti, what you have pointed out. We always make it like teach the juniors. It is always push the uterus cephaloid and retroverted for bladder and side dissection. So that lifts it up above the bowel also. And I think that was also. Let's move on to the next slide, next video.
Now, this is my last video, and before I give it back to madam. Now, there's again a case where, it's a huge uterus. You can see here, there's a previous 2 LSCs now. Now, Dr. Vandana, can you please guide me? Dr. Vandana?
Are you?
Yeah, please. I'm doing my dissection. We have seen Dr. Pandit Palaskar showing us how well we are doing.
So basically, you are directly going on the front. What we in previous LSCs do is we create a lateral window and then do
lateral window. The small video to lateral window kiya tha. Right. Now, the problem here is you can see here. Now, what do I do? What do I do now? Over here now.
So what I do in these cases is we create a lateral window, we dissect the uterus, we push the bladder down.
Yes. Now, if you can see here, you can see I'm just pushing. See what has happened now.
Yeah, you have a simple user from the venous bleed. You can just mop it, hold or wait for some time. Do not be in a hurry to cauterize it, because the moment you cauterize it, it can lead to some injury.
So now how to go about this? Amit sir, how do I go about this? Or how do I correct my mistake? Or how do I come out of my problem that I have created for myself?
One of the methods what you were using correctly is put a gauze piece there and start doing some other step for some time. Or what you can do, you can put some vasopressin in the cervix. That can also help in stopping the bleeding, and then you can get into the correct plane, because the facial plane between the cervix and the bladder, the loose areolar tissue is the correct plane. So rather than pushing the bladder bluntly, we should try to do a sharp dissection after elevating the bladder. And if there's any vessel coming in between, we should coagulate it simultaneously.
I think that is what sir has said and what I have gone wrong here. Can you see there is a small vessel over here, which I think I've just pushed inadvertently the vein over here, and that's actually bled. And I did, as Amit sir told, I did follow his advice. I immediately put a gauze piece over there. That's the best thing to do. Put in a gauze piece. It's a venous bleed and put it for some time. Give some traction. I think more often than not it does. But of course, lack of sometimes again, as I keep saying, stop learning from your mistakes. Yes,
the person from below can also give little more push so that there's good compression.
So again, as I said, these are the mistakes which we do, which we common things that we do not follow. And as sir said, just coagulate a bit, or else if it's on the bladder, again, I did say I use a gauze piece, push it for some time, wait for some time, and it will stop on its own. So basically, don't be in a hurry to coagulate over here. Of course, you can coagulate, but make sure, use of the left hand. You can see here, you're pushing the gauze piece. You've seen the vein over here. You can see a small vein. As Dr. Pandit had shown, you can see it. Can you see this vein here? This is a very, very clean area. What you saw over here was a very clean area. You can coagulate without any problem here. Because you've pushed down the bladder enough, you don't have to worry here. Again, the fat is over here, which gives a good end. So may I just invite Jyoti ma'am to please continue. Again, Amit sir, anything else that you would have done here by the time madam shares the screen?
Yeah, to prevent it or to treat this?
Prevent it, sir. Prevent it, of course.
Yeah. So
we are still in prevention is better than cure mode, sir. I am in the prevention mode. Madam is the senior pro.
So if you, as Damodar said, if you're not very sure about the plane, one of the vaginal assistants can put a gauze in the vagina and push upward so that delineate the plane between the bladder from the vagina and the cervix. So once you do that also, that helps to delineate and let you know how much you have to go down. Yes. And I think I'm more in for a sharp dissection of bladder rather than going for a blunt dissection.
Yes, sir.
Because we are taught in medical colleges, when we do abdominal hysterectomy, do a blunt dissection like we do it in cesarean. But then you get sufficient time. And in laparoscopy, vision is the most important thing. And if you're not having good hemostasis, then all your vision is gone.
So moving on to, we have completed now entry complications. So just quickly going through this for the benefit of audience. Stomach or bowel can get injured even with your Veress needle. Incorrect intubation and insufflation of stomach can lead to this. How do you diagnose? The abdomen is not uniformly distended and there can be regurgitation of stomach contents. So make sure that the stomach has been made empty when you're doing palmar point entry or high up entry. And although Veress needle injuries will heal spontaneously, but since you're inside, you would rather take a stitch. When you have injured through the port, while port insertion, if there has been a bowel injury, the causes are forceful entry, blunt trocars, and adhesions at the entry site. Diagnosis by fecal smell contamination and management is leave the trocar in place and then do primary repair or laparotomy. During entry, you can also injure the bladder. Causes would be where the bladder is full or pulled up by adhesions. Here you aspirate urine or you see the urine bag full of air, that is CO2. So that is pneumaturia. Treatment is Veress needle will heal, but you can just take a stitch, and prevention is empty the bladder before blind entry. So now coming to the next case. This is a very clean abdomen, but this woman has had earlier 5 cesareans, previous 5. She was an Iraqi woman. So as we entered, it was not so bad. And again, the proportion, there's no proportion, there's no correlation between the number of cesareans and the adhesions that you will find. So we find the bladder uterus hanging here. I see Dr. Aarti now, starting with you. How will you start? We do the round ligament, which is easy. Now, once we reach the bladder, what precautions and what techniques will you use? Dr. Aarti Luthra, please.
So we have to be very careful here. It is something similar to a lizard uterus, which is directly adherent to the anterior abdominal wall, and the bladder planes are also not very clear. In these kind of cases, I like to instill dilute vasopressin first, because my experience is that it separates the planes nicely and the oozing is also less. So
Where will you inject vasopressin? Where?
I'll just inject it over the fundus of the uterus, because that helps in separation of the planes. And then keeping my, I would like to do sharp dissection and gradually keeping my scissors towards the fundus of the uterus only. We have to gradually start dissecting, being very careful and finding the planes so that we can separate the uterus from the anterior abdominal wall before we proceed for hysterectomy. And of course, the patient is catheterized first so that the bladder is always empty.
Dr. Sudha, any comments? Dr. Sudha,
Yeah, so I think one has to be very careful, and a good amount of, pulling the uterus
down.
Good traction, either, I think, and only myoma spiral gives that much of traction as compared to any vaginal, that really. And if you can go a little slowly, lateral window technique, where you can see, try to, as much as you can dissect the cornal structures, you do it, but be little slow. And then once you are very sure that you can delineate the bladder, you can fill the bladder, as I think Aarti has already told you. Little bit.
Filling, yeah, that really helps.
That I don't know whether she told, but then you can fill with little 100 ml, of saline, with little methylene blue you can use.
Yeah.
So that also will give you some sort of the upper border. And once you have got a little bit of the plane where you're sure that you have dissected the fat with the bladder, fat belongs to the bladder, then lift that area and if you can cut towards the cervix or towards the uterus, so that that plane, if you get, so you really have to struggle, but I think being slow and
small steps
is very important, because this sort of bladder
one tip which I would like to give is what we do is, all these patients, they've just passed urine before coming to the OT. So once they're painted and draped, some amount of fluid has gone in. We put a catheter and we clamp it in the beginning. So by the time you put your trocars and you do your side dissection, the bladder is partially full. So in all previous cesareans, I make them, all my assistants, they've clamped the catheter in the beginning. And if it is too full, we empty it partially, but that gives you a clear margin. That is something
routinely use a K19 or use a Foley's?
No, that is patient, her own urine. Foley's we are using.
K19 or a Foley's?
Foley's we keep it clamped. During such surgeries, we don't take it. So let's move on to the.
Normally, we don't keep Foley's inflated because it interferes with the surgery. In such
not
cases,
really, 5 ml is quite enough, not too much, but 5 ml usually doesn't come in the way. So this was a patient where the cervix was very narrow. I mean, the vagina was very narrow. We could not put any manipulator. So we started cutting the cervix. The surgery was a little tricky, but not so difficult. I think the bladder had been difficult to dissect because of previous cesareans. So on a sponge on holder, we started doing this colpotomy, which was done easily. I'll just move it forwards. Then the suturing was also done. I'll just move it forward, coming to the last part. So the suturing has been finished. The video is visible, I hope, to all of you.
Yes, ma'am.
Yes, yeah.
Because the bladder dissection and all, there were adhesions. So usually we fill the bladder and see. So in this case, retrograde filling with methylene blue was done. And as you see, we move ahead further. So it was everything was looking fine till now. Mostly we would say, okay, everything is fine, and we would come out. But as we filled it further, we traced the ureters, the peristalsis, and then we found this. So we could have just stopped that everything is fine. But the small, maybe it was just waiting for more stretch to happen. So now what? What next? And starting with Dr. Damodar.
Yeah. One is you have to identify where exactly the rent is, and if the ureters are away. So if that is a through and through, you can even put your scope into it and see where the ureter is. If the ureter is really away, then you can suture it even with a barbed suture, say 3-0. or with the Vicryl 3.0. You can suture it in 1 layer or you can suture it in 2 layers, but generally we prefer 2-layer suturing. And of course, then you have to keep the Foleys in for about 2 weeks at least.
Yeah. So we do this routinely now. I mean, we have done after so many cases, and with passing years, you do a lot of complications also. So we are quite comfortable suturing. We feel bladder is the easiest organ to pardon. Of course, we don't do it intentionally. But then always a urologist, at least on phone, we tell them we are suturing. So this is very important when you are in a multi-specialty hospital or a place where an expert is available. It is very important that you take that person into the loop. If you're in a rural area, it's okay if you do everything yourself. So this we keep these patients, we just counsel them before surgery also that the only problem you may have is little bladder injury, but don't worry, we'll take a stitch, we'll send you with a catheter. So they're quite okay with the idea because they've heard from everywhere that this will be an open surgery. And we recheck. Sometimes you cover one hole and then you find there's another small defect. So make sure you again fill it with this and with a saline and check. And cystoscopy we usually do after this to make sure that we have been away from the ureter. The ureter jet.
Ma'am, I would like to add one point.
Yes,
so, as you've already mentioned that we do retrograde filling and see the extent of bladder. So while we are doing bladder dissection and we've already opened the round ligament and window and see the bladder, we can also use a bougie to see the exact extent of the bladder. That really helps a lot and prevents such injuries also.
True. Though we have not been using, but yeah, that thought has always come to our mind. Ureteric injuries, they are diagnosed most of the time post-operatively, 70%. So let us create a case before moving on to that. So a woman comes, you had a difficult surgery, you use a lot of cautery on the sides of the, near the cornu and near the uterosacral also probably you had to use. And she comes with some vaginal leak. She says, Doctor, pani aa raha hai. All the time my clothes are getting wet. So you call her and then what next? Of course, our heart palpitations have started. So when you call her to the OPD, what next? Dr. Aarti, we'll again start from you.
Yeah. So first of all, we have to see if she's smelling of urine, and we have to take the history if the leak is continuous. And then, of course, we have to find out the level of injury, what kind of fistula has been there. So we have to do a cystoscopy and see the defect.
She comes on day 5-6. She's come to the OPD. You make her lie down. You see per speculum.
Yeah.
So you see little urine-like watery thing. Then so what do you do?
Which post-op day? Like how many days?
5th, 6th day when she comes for suturing.
If there is slight leak of urine, it's better to put in a Foley's for 2 weeks and then see. A very small rent, it may heal, although day 6 is little late.
But I think we need to investigate her further. Dr. Amit, any role of taking that urine, that watery thing?
I think, yeah, because most of the time this fluid is a secretory fluid, a reactionary fluid from the vagina or from the pelvis, because sometimes these uteruses, they are full of adhesions and this reactionary fluid comes from the vault. If your vault is little open and you're always scared where you have injured the, whether you have injured the ureter or the bladder. So you take that fluid and get it tested for urea and creatinine content, and then you come to know, because of course you can put a cystoscope very easily and see whether there's something in the bladder, and most of the times there's nothing else. Or you can do a ureteroscopy also directly and see it.
But this is, we are talking in the OPD. So the first thing we can do before talking to them, to the relatives, also counseling them, because you have to subject them to another procedure. Send that sample for creatinine. That should be many times higher than the serum creatinine, urine sample. And then, of course, I think before taking her to OT and doing cystoscopy, we would not do a CT. Anybody to ask for a CT?
Ureterography can be done. Yeah. If we are suspecting
may I just add a point, ma'am?
Yes, please.
Sometimes, ma'am, what happens is, we know we are actually preparing for the worst, but sometimes what happens is it would actually be a case of urge incontinence or a stress, and patients do have this complaint of incomplete evacuation also, ma'am. So probably because of that also they may have leak of urine. This is a very rare entity, but then sometimes we should be lucky enough if we have something like that. So please do keep in mind that post surgery there may be some amount of urinary retention. The patient gives history of involuntary passage of urine sometimes, ma'am.
So I think after per speculum examination, sending that sample, the first thing which is easily available in every hospital is an ultrasound. So we look for ultrasound and check for any hydronephrosis, any collections, urinomas, which can be picked up before we go for CT. So just quickly to summarize this, diagnose post-operatively in 70% of cases. Mostly you don't see ureteric injury on the table. And why injuries are happening? Laceration, ligation, devascularization, and thermal injuries. These are the videos where, okay, let's move ahead. Symptoms are patient can come with flank pain and fever, abdominal pain, hematuria, peritonitis, paralytic ileus, not passing urine at all, and leak from vagina, or even from the abdominal sides, you may find watery discharge coming. And this could be the picture as you see in CT. This is hydronephrosis and a leak of the dye coming from a particular point. So you may find these can be the findings: free fluid, dilated ureter, hydronephrosis, leakage, narrowing of ureter, or absence of dye in the distal part, and treatment would be in along with the urologist. So stenting can help really, because sepsis with urine leaking in the peritoneal cavity can lead to a lot of damage. Sometimes they do percutaneous nephrostomy where they divert the urine for some time. Stenting may help, or they may require a surgical repair, but usually they avoid the urologists. They say immediately we'll do a PCN, because the ureters are edematous, they're inflamed. So they can't do a suturing immediately. And many cases would heal with just by stenting. And they say we take the patient in the OT with the fluoroscopy and all, saying if stenting is possible easily, we'll do it, otherwise a PCN. Now coming to this patient, let's see another case. We've talked of urine and bowel. Now another case of endometriosis.
Ma'am, we should do a cystoscopy post TLH, and we already know if the procedure has gone tough and we do not see a jet or ureteric reflux, we can do stenting at the same sitting also, because the surgeon knows what complication could have caused, or if you're suspecting in a very tough case. So why not? We can prevent a lot of complications from happening just by adding a simple cystoscopy after a TLH. After a difficult one at least.
One is seeing a jet is not confirmatory that injury has not happened. And should we, like many times we hold it for long, we don't see any peristalsis happening.
And I think that's the worst case to do, because you wait for so long and then you don't see a jet.
No, in that also we have some.
For a simple case, sometimes it really, gives you a lot of goof,
So what we do is
that
we
happens sometimes, Dr. Malia, when you've over distended the bladder. So sometimes just let the bladder fill and stop. Many times we used to overfill, that also stops peristalsis. But should we do stenting in all cases where we don't see?
Not in all, but yes, if they're suspecting, and if it's a dense endometriosis, cases of DIE, endometriosis with uterus or with dense adhesions. And ma'am, for jet, what we can do is we can give pyridium a day before or in the morning, so the urine gets orange. Also, one more thing, ma'am, when you're doing cystoscopy, deflate, remove the gas, so the compression on the organs decrease. And also sometimes if the blood pressure is stable, you can add your anesthetist, ask your anesthetist to give a little bit of Lasix. So in our cases, 99% of the times we are able to see the jet, which is reassuring for the patient, for the surgeon. And also if you think, even if you still think that you've gone or crossed near ureter, or the case was really tough, there is no harm in putting a stent for 6 weeks. And
this is a very gray zone. For in medicine, a lot of gray zones are there, because this patient will have to come back for removal of stent, which cannot be an OPD procedure. So again, it's a very gray zone, very difficult to say whether we should put in all difficult cases where we don't see a jet or not. But when you have an injury, then you feel, okay, we should have done it.
But I think for a small ureteric injury, more often than not with a stent. Now, you obviously had an injury. I think with a small ureteric injury, more often than not, they are actually very well treated with a stent. I think most of this in the panel would agree to that.
Totally agreed with that.
I think most of us would have some personal experience in that. So hopefully nobody has it, but then we have had somewhere where our hands have burnt.
We've had a lot of cases in our overall, I've seen in 10, 12 years, but most of the time it is simply treatable with a stent.
Okay, so let's move on to the
difference of opinion.
Well, I mean, it's a huge debate to go about peristalsis. If you look at peristalsis, ureteric or the opening and closing, it doesn't mean much. That I read even there's a case where right side the ureter was removed for a lady, she didn't have a kidney, but when they did the cystoscopy, there was the opening of the ureteric orifice. So, but like you said, if you give in pyridium or something and then you see the colored jet or something, then it probably means that it does not tell you much, but it can probably tell you that it is intact, that no laceration has occurred. It won't tell you much about thermal injury.
Thermal damage still cannot be assured.
If it is an injury because of electrosurgery, you may still see the jet and the
that's what thermal injuries.
Thermal injuries can present later. So I think this is a gray zone, as rightly told, and it's the discretion of the case and the surgeon, I would put it. No.
Yeah. So after at the end of any complicated surgery, we should do these cystoscopies or at least check the ureters and document it in your notes that you have checked the ureters. And this video is not playing. Let me just play it again. I'll go back to this slide now. So after this endometriosis surgery, a few years ago, we did a routine test, which is called Michelin test. You fill the pelvis with saline and you inject, you push in air from the rectum. You can use methylene blue or simple air. So here we found the bubbles. So nowadays, like many conferences, people say we don't prepare, we give them full meal one day before. I feel in difficult cases, endometriosis, we prepare the bowel, you can do primary repair. If you discover this, patient is saved of another major surgery, colostomy and septicemia. So it is good idea to prepare the bowel in all difficult cases, and primary repair was done and she healed well. Any difference of opinion on preparation?
For all my cases, ma'am, I do an aseptic syringe. In such case, I put an aseptic syringe at the end of the surgery, see for the air bubbles. And that's what I've learned from the gastro friends over here. Like you put an aseptic syringe and then push, same what we do the bubble test, ma'am. The bubble test, instead of putting a methylene blue per se. Yes.
But what you're talking about bowel preparation, I think that's a very valid point. If you're going to suspect, if it's endometriosis or previous multiple surgeries, it's always wise to do a bowel preparation and not just be gung-ho and say, no, it doesn't matter, I think it definitely, like you said, if there is an injury, you can do a primary repair then.
Yeah. Now coming to vascular injuries, some days after this, one second, when you go for rounds, you find this picture. So it's quite horrifying. We have been assuring the patient it will be a smooth surgery, and then next day you see this. So what do we do? What are these lesions? Dr. Vandana?
You're muted. Dr. Vandana, you're muted. Dr. Vandana, you're muted.
Okay, sorry. So see, the size of hematoma, you have to watch it, whether it is increasing or not. If it is increasing, then you have to definitely go open and then manage the bleeder. But if it is not increasing, continuously staying same, then you can give some anti-inflammatories and watch it. And even a tight compression bandage helps a lot of time.
Can I just add?
Yeah, please.
Yeah. So these are, I've had such an injury in a patient whom I did tubal ligation, honestly, and I was scared because it all depends. So on sonography, I did the sonography. She came on 3rd, 4th day with so much of blood coming out from the port. And did a sonography, it was almost the volume, it was in a subcutaneous fat. The entire collection was in the subcutaneous fat, nothing in the peritoneal cavity. And it was about 250 cc of blood. So I posted her for exploration, and I thought that I really need to open up. I spoke to another surgeon friend of mine. He said, you will not find any bleeder. There'll be just sheets and sheets of some blood clot, and you'll not be able to find a bleeder. Just sleep over it. Just don't do anything. And I just observed her, gave her hemoglobin did fall down from, I think 11, it came to around 7 or 8. I just gave her one IV iron. And it took about 14-15 days, or almost 3 weeks it took for the hematoma. Then it gradually, I kept doing the sonography, and then it kept on decreasing. So cover them up well with antibiotics.
Tranexamic, will it help? Tranexamic acid.
Yes, you can do that also. And same thing, even if there is, little bit after vaginal hysterectomy, there's little bit of bleeding and there's little bit of, it's nothing very, So, just give them good antibiotics, give a good wash, which I was giving, and kept her for 1 or 2 days, reassured her, and she did well without doing any other surgery. So that has been my
message. Yeah. So just watching would
and
be
if
fine.
she's on heparin, then we have to stop the heparin. I mean, most of the patients, I think we
of course.
put them on heparin.
So it depends on where you see the bleeding.
This is a case of inferior epigastric artery bleeding. So somewhere it has happened. Now immediately whatever's in your hand, like the harmonic was in my hand, so I started closing it. Then you realize it is not going to help, so you change over, take a suction and then a bipolar in your hand, and you try to coagulate. And what would you do next? I'll stop the video so as to have inputs from others. Dr. Aarti, you have been quiet.
Yeah. So
I'll try to coagulate, but net. Yeah.
Coagulation sometimes may not help if the spot is very big. We can take a stitch also, and it has happened with me also. And if you take a long needle and you can take a stitch through and through, you actually don't have to open it. And sometimes taking a stitch helps, and then you can just check for a while that it's not bleeding, and you can arrest the hemorrhage. We have never had the need to open it, but a through and through stitch from near the spurter can help. And of course, sometimes bipolar helps, but in this case, the mouth of the vessel is pretty big. It's cut all through. So better to put a stitch.
The port closing needle will
Yes,
really
exactly.
be helpful in these cases.
Yeah,
So this is what
prefer
all the layers of the abdomen will come with a port closure needle.
Yeah.
So this is what has been done
I've
after.
also seen people using a
So you
Foley's.
can take an intracorporeal suture also.
Yeah, you can. I mean,
sir, but sometimes, sir, we are not sure about whether we are able to get the full breadth of it, sir. That is the problem, sir. I mean, it's a very good idea. Of course, it's going to be very difficult because you're going to put anti-clockwise suture, sir. It's going to be very difficult. But suturing part, yeah, apart from the suturing part, I'm not sure whether we'll get the full layer, sir. That's a place where I'm a bit tensed about, where I would be skeptical about the intracorporeal suture part, sir.
So here we have done as the panelist suggested, we have put this suture. This is another picture I have taken. I have not done it, but I have taken this picture for the matter of discussion.
Yeah.
And sometimes when nothing is in hand, just put a Foley's. And
that's what Dr. Damodar had suggested sometime back.
Yeah.
Okay, achha. So we can put this, but make sure you, at the end of the surgery or later on, don't cut the Foley's. Make sure that you deflate it and then remove it. Otherwise, this ball will be very difficult to handle later on. So
again, when we put the port closure needle, the moment we tie it, always deflate the abdomen, and then you see. Once again, you inflate so that you ensure that the knot is very tight. Because even if the knot is slightly even loose, I think that can again cause a big problem. That's why.
That's a good point.
Yeah, and many times you find these at the end of the surgery when you are seeing, you find some serosal tears, this hematoma, small hematoma, and the omentum. So serosal tears, should they be closed, Dr. Amit, or any like little, not mucosa, muscularis has been injured. So do we need to close these? Sorry.
Yeah, I think I would prefer taking a stitch for serosal. You may leave
serosa can be left. Probably serosa can be left.
You know, if you're reaching up to the muscularis.
Yeah.
But only if there's a superficial serosal tear that you can use.
So maybe 1 or 2 cases we'll do and then we'll wind off because this is Mrs. SN, a very clean surgery. A patient, I'll quickly submit for you, a diabetic hypertensive obese woman with 2 NVDs. TLH was done. It was not no major problem. Uterus was just 12 week size and her weight was 95 kg. And during surgery, we realized suddenly everything was bleeding. So we realized that the pressure was, BP was 170/95. And on request, anesthetist brought it down. Surgery completed in time. Everything went off nicely. Next morning, patient has passes urine and she has had oral sips. And after 24 hours, she started having severe abdominal pain. On examination, abdomen was tense, distended, and bowel sounds were absent. Abdominal girth was increased. She did pass small stools, felt slightly better. So we felt, as surgeons, we are very protective about ourselves. We rarely try to accept that some problem might have happened when the CBC was normal. So what would be your suspicion, Dr. Damodar? Like what suspicion and what investigations? I think we can take it as the last case.
She might have probably gone to subacute obstruction or something like that. So sometimes after a hysterectomy, there's a lot of raw area that's left behind. And many times the bowel can go and get obstructed there. Initially, you will have like increased bowel sounds followed by, you know, what do you say? It goes into
ileus, I mean, sort of ileus.
You lose the bowel sound, yes.
Yeah.
So
what would be?
Have a delayed bowel activity because these diabetic patients, GI motility is little slow. So that can also be one of the causes, and they usually potassium levels are less.
Hypokalium is very, very common in such cases, sir.
Yeah.
You should wait and watch in these patients. Put them NPO.
Would you put a rise tube, Dr. Vandana? Would you put a rise tube for such patients?
Sorry?
Would you put a rise tube for such patients?
Until she's vomiting.
See, when the abdomen is very tightly distended, yes, we have put Riles tube in some of the patients and patient passes gas and they are completely relieved, but not always.
As a routine, would you advocate it as a routine?
No, not
that's
at
the
all.
that's the point. That's the point. So let's go back to that point. You know,
watch,
not all patients have subacute external obstruction.
I think electrolytes can be done, serum electrolytes.
Serum electrolytes.
And
just to tell you the history, what happened after this?
Hypokalemia does.
Yeah, electrolytes with potassium was little low, so they that was corrected. Ultrasound was one investigation which we just do in these cases. Ultrasound was done, and there was a small collection near the right side. Always we fear about left side sigmoid could have got injured. There was a small collection heterogeneous with septi on the right side. And then again, as surgeons, we are very protective. No, it was a clean cut surgery. I don't think there was no problem at all. But then we recall that, okay, 170/95 pressure, I had used more cautery. She was bleeding from every point in the beginning. So then we called in the surgeon just aspirated. They put in a needle and they aspirated, and it was fecal smell. So then she was. So, I mean, such things can happen in best of hands after many years also, when overconfidence also kills. But for the safety of patient, a laparotomy was done, and because some feces had, because even she was not even prepared. It was a simple adenomyosis, 10 to 12 week size uterus. Even bowel was not prepared. So
what was her pulse rate? I don't know. I missed it.
Pulse was 106, 110, but a little tachycardia.
That's a very early sign of.
The first sign, that something is wrong.
But within 24 hours, it was discovered, and she was like, surgery was done. So I think
first
we
thing that
conclude
happens is tachycardia in these patients, and that is
always hold the patient's hand. That they say, no, compassion, and it tells you so much.
What I like, Dr. Jyoti, is that you mentioned that she passed small stool. So we should not be reassured that the patient has passed small stool, and we are like, okay, fine, everything is good.
Yeah. And a mother-in-law, like, मैंने कहा था, he should eat less. He should, and with the family, we should not get carried away by emotions. We should be very scientific and straight in our approach. Dr. Malia, now let's conclude.
I think we'll just wind up in about. I always say, the eye sees what the mind. So always, as Madam did say, the check for the urinary bladder and the ectogy, what she showed in the case. Both the cases were actually straightforward cases. Again, but still, sometimes some things go wrong, and we have to be very careful. Now, how to avoid this, Damodar? You have any tips for this, Damodar?
So we're talking about ureters?
No, per se, completely.
Generally, okay, I mean, I have to talk about one organ at a time. If it's ureters, yes, I'm a person who likes to dissect the ureter out rather than stent it. I would do a stenting at the end of the procedure, not at the beginning of the procedure. If I, have a suspicion that there is some problem with the ureter, there could be some thermal injury. At the end of the procedure, I stent it. And what else are we talking about?
Anybody would agree to my first line: careful use of instruments.
Very important. Your installation has to be perfect.
Absolutely, sir. I have a couple of videos. I couldn't put it across where I have lost the more so when using a monopolar. I think most of us, myself, Jyoti Madam, many of us, we use monopolar when we open the vault. And then be very careful when we see with the coupling. Make sure that the coupling is good, because if there's anything of that, the covering is lost, and it can cause a lot of problems because of it.
Monopolar we use now only for PCO puncture, nothing else.
Sorry.
Monopolar is now used only for PCO puncture.
That is a
bladder dissection also.
I don't.
Colpotany also, a lot of people are using monopolar.
That is a debate for another day, Damu. That's a debate for another day. Use of monopolar. I think you probably recognize the problem half on.
They're using it for myomectomies also.
Yeah, yes, and
the last one, Amit sir, as Dr. Ramesh sir had shown, we did a modulation from below. You can tell me, I've had a problem here. There's a vein. How do I go about this? And it was shown. It was told by Dr. Ramesh. So I said,
I think the vaginal fornix got torn. So
yes,
that is one of
improper. That's very, very important. Your improper use of speculum. The speculum should always go behind the posterior and the anterior behind the bladder. If not, we'll have these problems.
Yes.
I think it doesn't usually stop with the coiling. A suturing is always a best part.
Yes. Yeah.
You have to take the
suturing is the answer for everything. But here on this case, definitely yes. Over here, another case for paucity of time, you just move it very fast. You open the wall. Again, a venous bleeder over here. Again, for most of them, venous bleeder, if it doesn't stop with with a bipolar, always suturing is always good. The same thing, a similar one over here. I think always most of this I keep showing this. Problems are always self-made. You can see it from here. Right. So tips to manage. I think Amit said, Sudha ma'am, senior most pro here. Sudha ma'am.
Yeah, I think you have put it very well. Don't panic. You must, even if you are not doing, you don't have many cases, assist many cases so that you see these small things, because you don't know, even attend workshops, attend conferences, so you learn these small points. Everywhere there's something new to learn. I think
anything on the last line? Anything on the last line what I've written?
Absolutely.
Conversion to open is not a defeat, and I would emphasize that whenever there is a bleeder, there is an injury, do good suction irrigation, see it first and then tackle it. Don't do it blindly, because that will increase the chances of injuring the surrounding organs. So it's very important to be patient, hold it with a bowel clamp, check it first before sorting it out.
I think the word you use is absolutely correct. Bubble clamp. Use always a bubble clamp to just clamp it. Okay. Now always make a good start. That's not well. Prepare and prevent rather than repair and repent is what I've learned from Dr. Punta Baker. You prepare and prevent rather than, that's why I've given more emphasis on prevention. Of course, in spite of our best bit. Now anticipate problems as all the seniors have told you, previous surgery, obese patients, inflammatory cases, large tumor, and a positive metastasis. Do anticipate some problems in this. Of course, good surgical knowledge, good surgical plan, good team, good instrumentation, good backup is definitely yes. There's a lot of debate going on Endoscopy Connect as of now about good backup and good team and good instrumentation. So that is one thing. Again, never make a decision when you are hungry, you're angry, you're lonely, and you're tired. So be always,
All.
Good,
Good.
That is a good one.
Yeah, that is right. So always make sure of this. Of course, conversion to laparoscopy open surgery is not a defeat, but a victory over complications. Egoistic approach should be banned and open a patient, open many once, then open once many. Technology, however advanced, has limitations. Of course, laws of averages. Now, defeat is not when you fall down, but when you refuse to get up. So every time you have a fall, please do get up and then. And this is very, very important what Mundroker has said. Complications are always not natural. Some of them are due to the less belief in forces of nature and most due to the over-enthusiastic practice of art. So do understand, as Jyoti Madam did say, in spite of best effort, we would have gone, everything would have gone well. Sometimes it does happen. Of course, can't blame it. It's our bad fate, okay, as is today. So Mundroker has put it very nicely for all of us to go home with have a very good sleep. That in spite of our best efforts, in spite of taking everything into sometimes, Naseem khota ho rata hai, kya kare? That's it. So I'll give the last word to Jyoti ma'am, senior pro over here, before we wind up.
Dr. Tulika was not able to join us. First of all, thank you all the panelists and that for this session and to make it so interactive and nice. A lot of messages what you have given will be helpful to me and to all the attendees. And thank you, UPIAG, Dr. Nutan ma'am, if she's here. She has been a guiding force.
May I just intervene for 10 seconds? I just saw Dr. Shobna Mohandas, who is the president of the Indian Menopause Society, who has joined us. I think I welcome Dr. Shobna Mohandas for this session here, ma'am. I think we did see Dr. Shobna Mohandas here. It is a pleasure, ma'am, to have you. She's the current president of the Indian Menopause Society here.
Okay, great.
Yes, ma'am.
Welcome, Dr. Shobna. I can see. So I think we should conclude here because we had promised to be till 6 and the panel is something ongoing. We can keep talking over night about so many topics. Thank you, Dr. Subhash, for being such a good co-moderator with me and with such interesting slides which you had prepared. So we could actually go in a flow because otherwise alone it looks very random where to start from and where to go. And Dr. Sudha, it is so nice to catch up with you, although on a webinar.
I think I have to compliment Jyoti ma'am because she has been a very, very professional in this. We did have a talk, 48 hours prior to this. She went through how the flow should go on and she did it pretty well, and I'm really thankful.
I think you both deserve a big round of applause.
Thank you very much.
Thank
you very much, Sudha madam.
Thank you very much.
Aarti madam, Dr. Amit sir, Damu, Dr. Vandana, Sushila, I really miss Sushila over here. Thank you very much, Usha madam, and all the senior pros. I think Dr. Bhaskar Pal, Dr. Narendra Malhotra sir, Dr. Rajesh Modi, Dr. Pandit Palaskar sir, Dr. Nutan Jain madam, and Dr.
Okay. Dr. Nutan is not here. Dr. Nutan ma'am, I should especially thank you because I was really having sleepless nights and Madam's IT team came to rescue me. I was trying to understand Zoom, but not so well. So they have really been managing this very well. Dr. Vandana, I think you can thank Madam from
sure. Thank you so much.
And thank you all for joining us. And Dr. Uri ma'am.
Nice to catch up with you for a long time. I have not met Amritsar for a long time.
Yes.
I think we can end this meeting now. Thank you all the attendees.
Thank you.
Thank you, Damodar. Thank you very much.
Thank you. Bye-bye. Bye-bye.
Thank you.